Thank you. Good morning, everyone. I'm Kevin Orford, Chair of NHS Devon. Welcome to the March 2025 meeting of the Board of NHS Devon, the Devon Integrated Care Board. This is a meeting held in public, which is streaming live to our YouTube channel. We have apologies today from John Finn, our Acting Chief Operating Officer, but we welcome Louise Higgins, Locality Director North and East, who is deputising for John. We have apologies from Mark Cook, the Managing Director at NHS England South West, and I think we're expecting, in fact we do have Richard Schofield, Director of System Coordination, who's joining us online, who is deputising for Mark today. We have apologies from Lincoln Sargent for the meeting today. We also welcome to their first board meeting our three recently appointed non-executive directors, Salma Ali, Kay Bentley and Lopa Patel. Welcome to all three of you. Joining us also today we have Sarah Launton from Health Watch and Nicola Bonus, Deputy Director of Communications and Engagement, who will be presenting the agenda item for our People and Communities section. Also with us we have Alison Williams, the System Recovery Director for NHS England. And online, we have Frank O'Kelly, Partner Member for Primary Care Services Providers, and Donna Manson, the Partner Member for Local Authorities. And we note, Donna, that you'll need to leave after 10:30 a.m. this morning to attend another meeting. We're also expecting non-executive member Tandy Hara to join us online shortly, and Kate Shields, Chief Executive Officer of Cornwall and Isles of Scilly ICB, will be joining us at approximately 10:30 due to her attending a Cornwall Extraordinary Board meeting this morning. We also welcome members of the public viewing the meeting online. I'd like to remind everybody that this is a meeting in public and not a public meeting. So before we start, can I confirm, Philippa, that the meeting is quorate?
Yes, it is.
Thank you very much. So if we can move to item 1.2 on the agenda, which is the declarations of interest. These are listed in the pack in the Register of Interest. Is there anything which anyone wants to add to the declarations, or anything which we need to draw to the attention of the board relating to today's agenda? And we note, Richard Schofield, we note you've made a nil declaration and we'll record that for the minutes, but is there anything else anyone wants to draw to our attention? Kay.
Thank you, Chair. If I just draw the board's attention to agenda item around specialised commissioning delegation. It's in my declaration of interest, but I am the independent chair of the South West Joint Specialised Services Committee. Thank you.
Thanks, Kay. We'll note that interest. Any other points which anyone wants to flag up? Okay, in that case, we note the declarations of interest. We then move to item 1.3, which is the minutes of the meeting held on the 30th of January 2025. Can I ask, first of all, if there are any points of accuracy which board members wish to raise relating to the minutes? Okay, if not, there is one comment regarding the accuracy which we have received from outside of the board. So you may recall that at the 30th of January meeting, Dr. Imran Jaitam and Dr. John Whitehead submitted a question, and since that time, Dr. Jaitam has been in correspondence with our Chief Medical Officer. And in his most recent letter, there's an assertion that his question was not raised at the meeting or recorded in the minutes. So I would draw the attention of members to section 8.1 of the minutes, which provides an overview of the question and our response to it. And a written response has also been provided to Dr. Jaitam. So if there are no other points of accuracy, we can approve the minutes of the meeting of the 30th of January. Let's move to the action register, and we're asked to agree the closure of the following actions. So I'll just read through what it is we're closing. And if anyone disagrees with the closure of these, could you indicate to me that you're not in agreement? So action 69 relates to the equitable funding for hospices. This is addressed in the CEO's report, agenda item 2.2 today. Is everyone happy to close that action? Action 24.9 relates to decision-making structures for commissioning, and this is addressed in the agenda item at 4.2, relating to agenda item 4.2 today. Is everyone happy to close that item? Action 38 relates to QPEC oversight of the merger of Devon and Cornwall LMNS, where we note progress reports are presented to each Quality and Patient Experience Committee. Are we happy to close that action? Action 91 relates to board receipt of a closure report from the Primary Care Commissioning Transition Committee, and this is included as agenda item 4.2 today. Is everyone happy to close that action? And finally, action 1022 relates to linking the OD plan more explicitly to the staff survey, and this is addressed at item 2.3 on the agenda today. Is everyone happy to close that action? Okay, we note also the updates in respect of actions ICB 241022 and action 111. We note also that work is underway with regard to the risk action 1021, with that being completed by the end of the month. Okay, if there are no comments on that, let's note the action register, and we can therefore move to item 1.5 on the agenda, which is our people and communities section, engaging on the NHS 10-year plan. So we welcome from Health Watch Sarah Lonton, who's going to share with us the joint work that Health Watch have done with NHS Devon on the engagement around the NHS 10-year plan. But before we bring Sarah in, I'd just like to invite Nicola, NHS Devon's Deputy Director of Communications and Engagement, to say a few words about the approach taken to the engagement. Thank you, Nicola.
Thank you, Chair. Yes, Sarah is going to talk through where we've worked collectively across Devon with all partners. Health Watch have been intrinsically linked with us throughout that, but also all of our NHS partners and voluntary care sector partners have worked with us to deliver what I think is a really good output in a very short space of time. So we've now heard from over 3,500 people across Devon in terms of their views around the 3 strategic shifts that have been set out by the government. And as a result of that engagement, we have over 200 people who've asked to work with us on an ongoing basis. So in terms of our strategy development, commissioning, service redesign, they're really keen to work with us, and how we work with them is still open for us to design in terms of what's best suited for our needs. One of the big achievements is we've delivered over 50 workshops, which constitutes to 10% of the total amount of workshops that have been delivered nationally in Devon. So with the help of Health Watch and also the voluntary care sector and assembly, who've supported 17 workshops delivered with very specific bespoke communities. So I won't steal Sarah's thunder, and I'll ask her to run through her slides.
Thank you. Firstly, thank you for the invite to the board. It's much appreciated, and I think Health Watch has really welcomed the approach that we have taken through the NHS 10-year plan engagement at a local level, and definitely within Health Watch England, they have really taken note as well, because it was quite unique across the Health Watch network. So always like that when we can elevate ourselves at a local level. So that was really good. If I could just move on to the first slide, that would be great. So I just wanted to share with you why we felt it was really great to work together in this new way, of almost like this new model, which hopefully we can develop as we move forward. Firstly, it was really great to be involved in the initial planning. Quite often we hear, we've got this idea, we've got this model, how are we going to take that out to our community? But actually we came in a step before that, which was really welcomed and really appreciated. We were involved with the discussions about how are we going to do this at a national level, how are we going to bring that down locally? And I think during that journey, we did identify some key areas which maybe shifted the way we were going to do that, i.e. that we weren't going to get the data necessarily and hear our voices from our local people, which was invaluable to find out at the beginning. So it was great to be involved in the planning. It was great from a communication aspect, both internally and externally. We felt we had a really good link to be able to come into all our partners working on this piece of engagement to share our ideas, but also have that consistent message going back out to our public, which I think as we go through the slides was extremely welcomed. Sharing resources, we're all strapped for resources at the moment. We're all sort of really struggling. And that was really great that we could actually share our volunteers, our staffing, our free post for those that were unable to get online digitally, but also offer assistance to those that were unable to maybe access the forms and complete them themselves. They needed additional support. So we were able to offer our free phone line and actually support people doing that over the phone and collecting their feedback that way. Sharing networks as well from the community and other stakeholders, that was really invaluable to make sure we really were able to map at that planning stage the best reach we could get with the resources that we had in a limited time frame. So that was really a good opportunity to look at how we could work more collectively. And say linking the skills that each organisation had. So it was great when the NHS team, Nicola, Steve, John, etc., were able to come to our staff meeting and our volunteers, because it's really invaluable. I can sit and talk to my staff about the NHS plan, but it's great when NHS members, professionals come and actually deliver it from their perspective as well. So it gave them a better insight, they were better informed when they were going out to speak to our general population. But also, our skill set is our community. We were able to support the NHS plan to actually go out and make those connections and actually also capture the voices in different ways. I'm hoping you've all seen some of the videos that have gone out, especially the children's one. I did have a smile at a few of the comments that were made on that. But again, that's a different skill set that we could just bring in to really elevate that patient voice and that service user voice through this process. So some of the benefits, as I say, we found from this collaborative approach was a consistent messaging to our local population. We hear time and time again, I'm asked for a bit of feedback on this, I'm asked for another piece of feedback on something else. I can't see how it's joined up, I can't see how it's working. So it was felt that this was really clear messaging and we were all pulling together with the same message to our local population, which was a great benefit. Sharing intelligence and obviously joined up working. That speaks for itself. It was a huge benefit. We found out what we already knew. We could also work across what other engagement was happening with other work streams as well and see that where we could share the feedback that we were gathering through the 10-year plan to help inform other pieces of work. And also working in partnership really enabled us to deliver really quite a big piece of engagement work in a short period of time. It really was a quick turnaround time, especially I think the team will agree that we worked with in NHS Devon around the workshops, and they had to be converted to make sure they really reflected and resonated with our local people. So that was turned around extremely quickly. Put a smiley face against one of these. I was extremely pleased in Healthwatch that we were not analysing all the feedback that was coming back. Really appreciated that. And I do look forward to seeing the report when it comes out in the coming weeks, hopefully, about the feedback and what people are saying. But also as well, being able to reflect on the NIDA is going to be really good. We haven't done it yet in any great detail, but I welcome the opportunity to work with you as partners to reflect on what worked well, where we can build on the model that we're sort of developing to enhance that when we go out for future engagement work. And on the next slide, I've just added a couple of photographs. I'm sure you've seen some of them, but really our reach across the community. Just to give you a flavour, we went to some of the colleges and spoke to people there. The student unions were great. Actually, they were dragging people down to talk to us. You really need to come and talk to Healthwatch and share your feedback. We had a huge audience, as you see, from the U3A and Ivy Bridge. I think we packed out the auditorium there, so that was really great. And as I say, a picture of the team as well coming to speak to our members of staff and volunteers, which was really welcomed. So if I can just move on to my final slide. As I say, I'm really pleased you're analysing the feedback, and I look forward to seeing that in detail. So I just wanted to share what really we were picking up through the conversations we had when we were facilitating the workshops and supporting some of the events that we did ourselves, but also worked in partnership with NHS Devon. So the overall message really was, it was great to feel included and have the opportunity to actually offer our ideas and solutions. I think if you've seen some of the videos, you'll see actually people, which was unscripted. They were very kind to stop and talk to our cameraman and just sort of give their feedback about how they felt after the workshops. And it was a feeling of, I actually had an opportunity, and it was great to have NHS in the room to listen. They really felt that was a value. Also understanding the direction of travel. I think that came out quite strongly. It was great to hear. We know there were issues. It was great that they were acknowledged. I think the public on the whole are very aware of the challenges within NHS England. But locally, it was good to see what the direction of travel was in the long term and how this fitted in and how their voice and their feedback was going to make a difference. And the other thing was that they said overall, when they receive services, they're good. In general, the issue they have is around accessing them. The public, interestingly, when we spoke to a lot of our public, they weren't aware of the National NHS 10-year plan consultation. So I think this piece of work that we did was invaluable because they would not have fed back nationally, and it really brought it onto their radar, which was really great. A couple of bits on the three main aspects that we picked up on. Obviously the digital poverty, accessibility. There is concern about how accessible that is through digital technology, and also a request that kept coming out about let's have one digital application, an app that we can use to get results, to book appointments. They're all very different for hospitals, for GPs, etc. So as we move forward, that was something that we heard very strongly from our population. Sickness to prevention, that was very much needing a diagnosis early and looking at ways that we can build more healthy communities. And I know there's work in the pipeline with regards to healthy neighbourhoods, etc., that will hopefully drive that forward. And over acute community, there was a concern in key areas around some of the lack of the community services over the recent years that have been withdrawn, stood down, decreased. There was concern over GP access. We hear that all the time through Healthwatch. And also some of the impact around the collective action because of the timing of this piece of work as well. People having to travel further in some cases to get blood tests, etc., maybe from a hospital rather than their local GPs. But most agreed with closer to home is better, providing that local offer was consistent and stable. So if they knew they turned up, what service they were going to receive, the times that they were, the service was open. So for us as Healthwatch, I think the highlights really of working in partnership from the start was invaluable. We really felt involved, and I welcome that. And as I say, moving forward, I wish for that to sort of continue. Capturing a good cross-section of the community, as I've mentioned. In summary, I don't think we would have done that. I'm not sure how many of those 3,500 people would have replied if we'd left it just to the national engagement being sent out, a bit on television, but a lot of people, as I said, didn't even register with them what that was or inspire them to actually get involved and to feed back, which it did at a local level, and I strongly believe that. And also, this partnership working has really made sure we've cemented and started to map our resource capacity through Healthwatch in the community, through the NHS providers and VCSE. So we really are starting to hear the voice, which is what Healthwatch is all about, from our local community strongly. Thank you.
Thank you, Sarah. That's a really clear presentation of what I think has been a huge success for NHS Devon and Healthwatch in terms of the 10-year plan engagement. We've just got a few minutes if anyone's got any questions for Sarah and Nicola or any observations. Salma.
One from me, Thank you very much for the presentation and the supportive paper. I thought both were really helpful in kind of focusing on the key issues. I just wondered, do you have any plans to profile the information that you have received to see how reflective it is of Devon in terms of gender, locations, etc.? So we've got a repository of information and then perhaps see where the gaps are and then follow those through with some perhaps more targeted surveys?
I think Sarah's looking at me. I'll take that one because we're picking up the analysis, as Sarah said. So we're really fortunate that actually we have somebody from NHS England South West who's supporting us in terms of doing the analysis, who's really skilled in doing that work that you outlined, Salma. So yeah, we will really have a lot of detail around who we heard from, where they're based. He's done what is called a heat map, so we can actually see where that came from. And also, as we go forward, any gaps that we do identify, we can pick up in our ongoing work framework, because this is just the start of a conversation. We now have to think about how we embed that in what we're doing long term in terms of our strategy development. So,
Thanks. Lopa.
Again, I wanted to say thank you as well. It's a really interesting piece of research, and what I'm particularly interested in is the comments that you received about digital inclusion. So I wondered, does Healthwatch have particular plans around trying to improve digital inclusion, given that we already have the NHS app, and if we could just communicate more with people about the NHS app, that might help.
Within Healthwatch, it's actually on our piece of work for this coming year. So around September, because we understand there's some changes happening to the NHS app. So we thought we'll wait for those to happen and then actually work with our population to get access to the app, help them understand that and navigate it. Because quite often we bring out digital technology without any training and insight on how to use that technology. So we see our role as not only informing, but helping to provide that training and insight on how to use the applications as they move forward.
Thanks. So I've got Martin and Frank, and then we'll take some final comments from Steve after that. So Martin.
Thanks, Kevin. Great report and a really good framework. I suppose my question is sort of to us in a way, which is, I can see in the example of the 10-year plan, how the feedback has been, useful and sort of sent more up the line. But in terms of ourselves, how does this framework give us that opportunity to take voices into our choices that we're making as an NHS here? Is that through some of our committees or through this board? And how's it going to work ongoing? Is it a case-by-case basis, or is it a sort of ongoing thing?
So could I ask Nicola to respond to that, please?
Yes, so one of the things I was going to outline when we talk about the framework is that one of the things that we have done for the first time ever, I think, is we've embedded the framework in our governance process. So we will be reporting through the Population Health Committee up to this board, so that you will be hearing what our population is saying, and there is a responsibility to hold ourselves and yourselves to account in that space. So it will be in place after this meeting today if board are approving of the approach.
Thanks, Nicola. Was it on that point, Penny? Do you want to just come in then?
Thank you, Chair. And such a key point. And of course, with the quality impact assessment, which it should not only be used when we are looking at SIPs, cost improvement plans, it should be look at our strategic commissioning intention. And so we've been looking to build that in as an integral part of our commissioning approach right at the inception stage. And the revised policy is very clear about the need to really seek the views of those people, not only who use those services, but of the broader population.
Thanks, Penny. And Frank, please.
Thank you. I personally think this is one of the most important papers that's come to us in the 2.5 years I've been involved in the ICB. And the reason I say that, I feel that this is the glue that will sort of bring services together. Ultimately, we're a service industry, and this is a systematised way of finding out what happens, what matters to people. It feeds up into the Devon Engagement Partnership. There's an online resource, there's a library, and having a library of what's happened before is power, because information is power. And then there's the formal reporting system. And the thing that I think is most important is it turns it into everybody's business. It's not just the ICBs, it's any of the organisations that are trying to change things will have a process to go through. So my congratulations to the comms team and to Healthwatch. I think this is great.
Thanks, Frank. And final comment on this from you, Steve, please.
Yeah, thank you. And it probably builds on that point and Martin's point. I think there are actually two unique aspects to this, I think, for Devon. One is the partnership that we have with Healthwatch now, and it's great to hear your feedback, Sarah. That's, for me, that's how we want to continue to work. So this isn't a one-off thing, because actually, given the challenges and the things that the NHS needs to be looking at over the next few years, how we can work really closely together to ensure those community voices are heard is going to be really important. The second thing, which I think links to Martin's point, is I think we were fairly unique in being able to do our own analysis locally, which means that for other places, a lot of the feedback would have just gone into the national pot. We have got the ability to use this significant amount of feedback that we've had in order to inform not just next year's plan, but our plans going forward. And I do think, you know, for those members of the public who are willing to come and give us their feedback, it's incumbent upon us to use that in the best way possible. So I would see this as a great example of how the ICB, I think, has moved on significantly, really led by Nicola and the team, to get us to the point where I think we need to be, which is that we are continuously engaging in a humble and open-minded way with our public as we try and guide the NHS through some quite challenging times ahead. So I would just commend all of the work that's happened, and Sarah, give you the reassurance that this is the way we want to continue to work.
Thanks, Steve, and thanks, Sarah. We really value the relationship that we have with Healthwatch and the work that we do together, and so I just want to thank you and the whole Healthwatch team for the invaluable support to the work on the 10-year plan engagement, and also thanks to the ICB comms team. A number of them are in the room today. Thank you for all the work that you did in leading this hugely important exercise for us, so thank you. We move smoothly then into item 1.6, which is very aligned to what we've just been discussing, the People and Communities Framework. So I'm going to ask Philippa if she will introduce that, please.
Thank you. So very brief comments. So I think a number of comments have already been made on the framework, which we really welcome. I think it represents more than 6 months' work and a real change in approach for the ICB over the past year in terms of communications and engagement, which I think those of you who know that I'm not from a natural communications background has meant a huge learning curve for me as well. And I think it's been incredibly valuable for us all to start thinking about what we need to do to bring engagement into what we do. So I think at that point I'll just hand over to our real comms lead, Nicola.
Thank you, Philippa, and I do want to echo what you said and thank my team in the room, because a huge amount of effort has gone into getting this here, and that's because we are very passionate and ambitious about what we want to achieve in this space and to support this organisation to do the right things by our population. Sometimes those will be difficult, but we need to be having those open, transparent conversations, and the framework enables us to do that. And the key things I really want to say, because obviously you've read the paper and you know the content, but this is a moment in time. It represents a lot of goodwill and energy and the start of opportunity and alignment, but we know there's more and it will evolve. It isn't sort of the final product, but it is a good flavour of where we can get to. So I think I just wanted to say that. Why do we need it? Frank alluded to a lot of this, which is great, is that we have so much good engagement going on across Devon on a daily basis with partners and various organisations, but what we don't do is bring that into one single place and really understand and really understand what the consistent key themes are that are coming up. And we all agree we could be better to coordinate things, like Sarah is so well described in terms of the 10-year plan. So that this gives us the opportunity to do that, and also think about how we have that 360 dialogue with our population. So we tell them what we're doing with what they say and what that's influencing and what we're implementing with it. So the framework has 4 key elements. It has the Devon Engagement Partnership, which brings together all of those people in each of our organisations who are out there talking to our population at a neighbourhood, place and a system level, and brings together all of their views, findings, and together we think about what's the best approach, what do we do with those things. And it's in its infancy, and we do want to widen the membership, and we've started to talk to the One Devon partnership about how we bring in our local authority partners, which Mary's kindly linked us with some people at Plymouth City Council, and we'll do the same with Devon and Torbay. So they will be key, and what we've looked at with the 10-year plan is how we use subgroups as part of that group as well. So there's some real opportunity there to build that and really start to drive things forward. We'll have the Insights Library, so we have one single place on the One Devon website where all of the feedback that we're getting is in one single place, which really is there to help all of our organisation in terms of service design, commissioning, strategy. It should become the way in which we work, the first place we go to see what we know already, because we don't want to go out and ask people the same things we've asked them hundreds of times. The involvement platform, a little bit like they've done nationally with the 10-year plan change website, will give people the opportunity to use that as a tool digitally online, and there will obviously be lots of other mechanisms and methods for people to be involved with us, but having a platform in one place enables partners to use that as well. And then finally, as I said earlier on, ensuring that we are providing assurance to this board and that there's a proper governance process around this. Will now be reporting through the Population Health Committee. So that's what the framework is based on, and really welcome your thoughts and comments.
Thanks very much, Nicola. Any comments, questions for Nicola? I've got Loper, Graham and Sam. Loper, please.
Thank you. Really great piece of work, Nicola. I commend you on it. I had a couple of questions. The first one I think you picked up on, which is the feedback mechanism, which is the 360. But more than the 360, what is the closing the loop approach, which is that you've created a get involved platform and people are involved and they will continue to be involved. But what is the closing of that loop plan? And then the second question is about the Devon Engagement Partnership itself. Is it sufficiently reflective of the Devon communities? And what are the gaps? And if there are gaps, what are the plans to address some of those gaps?
So I'll just pick up the first one. So on closing the loop, I think you're absolutely right. Obviously, one formal mechanism will be that we'll be producing a report that will come to Population Committee, which will say what's happened with the various pieces of feedback. So that's one route. And obviously, we'll need to be thinking about, for the people involved, how we go back to them. And what the website will enable us to do is to put those mechanisms in place. So, for example, the 200 people who have requested to be involved with us on an ongoing basis, we would look for that to be a regular dialogue with them, whether that be a newsletter or we need to develop those type of tools. But absolutely, we need to be making sure that we get back to them in the ways that are best suitable for them as well. And sometimes that may even be face-to-face events as well. So yes, it is in our planning, but we're still developing it with the engagement partnership. On the second point, in terms of representation, I think we all agree on the partnership that we want it to be a lot wider. I think we started with key partners who we work with on a regular basis. So we have Voluntary Care Sector Assembly and some of their members. We have Health Watch, we have local care partnerships, and we have NHS providers. We knew from the beginning that we really wanted to involve local authorities in that space, but we need to work with them about where that's best linked into, because obviously a lot of involvement and engagement goes on across all places in the local authorities. So we need to understand with them where that best sits. So we need to continue evolving that membership and probably look to put some terms of reference around it formally at some point.
So just to follow up on that, so does the further work on that and the terms of reference, would that come into Population Health Committee in the first place, Nicola?
Yes.
Good. Thank you. That's great. Graham, please.
Thank you. So I think some of the comments we've previously heard I endorse very much about the flow both in and out of, as it were, board around the voice of population is really, really central. So my question is then about coming through the population health path, which has the benefits of being a single path. However, there are other committees, and I would cite, I guess, quality being one and finance and performance being the other, that will also be pertinent to this going forward. How do we think that will work? Have you given that any consideration, please?
Yes, I can give an example of that. So part of the reason why engagement, I think, didn't have a formal governance home was because it was collected together with patient experience. So what we have done through developing the framework, working with the patient experience team and the committee is talk about how we have a link across for both committees, because patient experience is still in people's views, but it tends to look back on experiences, whereas engagement involvement looks forward and how we change things going ahead. So we have looked at that. We are linking with those teams behind the scenes, so we are really conscious that there needs to be a read across with all of those committees so that we capture all of the information that's coming through. So I think that will be the first real test in how we continue to link patient experience and involvement engagement.
Thanks, Nicola. Sam, please.
Thanks. This is really important, isn't it? The bit I'm just thinking about is the online bit that you talk about in your paper, because I'm a bit worried we're going to end up with parallel platforms. So our patient portal that we've got in East and North is called MyChart. We've got 130,000 patients already signed up to that. They access all their results. Very soon they're going to be able to book their appointments. So we have something that runs already. And I recognise this is something slightly different, but there is a danger we're asking the same people to access two different platforms, and I'm not sure what the answer to that is, and maybe we just need to do some work offline on that.
I'll just pick that up. I didn't know if, Sarah, you had anything on that, but because obviously they have portals as well where information comes through. But obviously the beauty of the engagement partnership will have representation from all partners organisations, and we would want to know where those platforms or portals exist, and we think about how we bring them together. So our online platform, I suppose, will be of real benefit for people who don't have that facility. But, wider organisations, particularly voluntary care sector, may not have that sort of place to collect that information. So I don't think we need one single in isolation. We do need to think about how they link together, but this is us providing a solution for people who don't have it as well.
Do you want to come back on that at all, Sam?
Well, I mean, it's a more complicated conversation, isn't it? So I'm just conscious we've got plans as a system to roll out Epic to West and South. So within the 2 years, we will have a consistent patient portal across the whole of Devon. So it's then how do we align the coverage, isn't it? But yeah.
Can I just bring Peter in on that point? Thanks, Peter.
Thanks. I'd agree with you, Sam, and I think perhaps we need to reframe the conversation with the public that says that we can't have a single app because we're trying to do a number of things, but what we can do is have a consistent signposting to the apps that we use within Devon as a health community, and help educate people, help empower them to use the right thing for the right thing. I think we're all used to having different apps for the different shops that we use, but they all sit under a shopping thing on our phone, for instance. And I think it is about being able to create the right narrative that will help our public engage in the right way.
That's helpful, Peter. Thank you. Is there anything you want to add to that, Nicola, before we close this item?
No, I think that's right, and I do think it is a conversation behind the scenes about how we do that with our partners. So we'll pick that up, Sam. Thank you.
Thanks, Nicola. So we're asked. Richard's put his hand up. Oh, I'm sorry, Richard. You wanted to come in as a last comment, please.
Yeah, thanks, Kevin. I'm sorry to have my camera off. I've got a bad back, so I only sit down when I'm speaking. So I think it's a nice problem to have, the last couple of comments, particularly from Sam, that you have an overarching system approach to developing public engagement techniques that can then inform specific proposals. I completely get that there needs to be synergy between the different platforms that you use, and that's a technical conversation. But this is a problem that of the 42 ICBs in the country, very few have got this very nice problem to have about how you tie different sources of information together, but within an overarching framework. And I can only commend the work that Nicola and the team have done around this, because it is absolutely leading the country in the way we do this work.
Thank you, Richard. That's a very, very helpful observation. Thank you very much for that. So from there, we're asked to approve the People and Communities Framework. Is the board happy to approve the framework? Thank you. We're also asked to take satisfactory assurance from the development of the Devon Engagement Partnership in the intention to embed the approach into the governance of NHS Devon. Do we take satisfactory assurance? Thank you. And we're also asked to note the approach to the 10-year plan as the blueprint for effective collaboration on inclusive and meaningful engagement. Thank you very much, and thank you, Nicola, and thanks again, Sarah, for your work on that. We can now move on to the leadership reports, and we'll do my own report first. I'm going to take the report as read, but just a few issues to highlight to the board, and there is a recommendation for action. So firstly, just want to acknowledge the announcement of the disestablishment of NHS England, and then the subsequent announcement on the requirement of significant reductions to staffing costs of ICBs. The Chief Executive will refer to this in his report, and we are waiting for further guidance to understand the detail of the requirement on us, and we'll keep the board and our staff and our stakeholders appraised of any developments on that over the next couple of weeks. Secondly, I'm just referencing our thanks to both Martin Sykes and Judy Hargadon. Martin has been a board member here since last autumn to backfill me when I was acting chair. I've been really grateful for Martin's support over the last few months. And Judy has been on the ICB board for 3 years now, and was on the Clinical Commissioning Group board for 3 years before that. And we thank you for all of the work that you've done for us, Judy. So thank you to both of us. We'll miss both of you. Section 9 of my report sets out the conclusion of our annual review of the board roles. So I'll draw the attention of the board to the appointment of Lopa Patel as the Deputy Chair to the board. Lopa and I will agree the detail of the scope of that role over the next month or so. Congratulations, Lopa. Since the report was written, I'm recommending that we also add a health and wellbeing guardian to board roles. This will bring us into line with many NHS trusts and many ICBs, and we propose that we add this to the INM board roles, and I'm pleased to say that Salma Ali has agreed to be appointed to that role. And I also draw attention to section 20 of the report, which sets out the appointments that I have made under delegated authority of the board to our board subcommittees. So are there any questions from board members on my report? So if not, can we note the contents of the report? Can we please approve the proposed allocation of board roles and responsibilities? Thank you. And can we note the exercise of authorities delegated by the board? Thank you very much. We can now move on to the Chief Executive's report. Thank you, Steve.
Yeah, thank you, Chair. So in a similar vein, there's a number of things in the report that I don't plan to particularly highlight today, but clearly happy to take questions on any of them, and we've trailed a few already. But I did want to start in the same place as the Chair and just recognise recent announcements and that to acknowledge that actually as an organisation we are entering a further period of uncertainty. We've had a number of conversations with staff, as you might expect, and so I know some of you have been involved in those. The commitment to staff has been twofold, really. Firstly, that we ensure that as things become known, that we communicate that effectively and swiftly, because clearly for people working within the ICB, that's going to be really important to how people plan their futures. And secondly, that we are as an organisation, particularly given the journey we've been on around our the values and behaviours work that we've done, a real sense that actually we want to be all in this together, that we need to support each other and look out for each other. And the best antidote to that, as I said at the recent staff meeting, is we have a huge day job to do, and as far as possible in these really difficult times, focusing on the thing in hand is probably more conducive to sort of your well-being than worrying and speculating about things that are not yet known. So that's been our commitment and our conversation with staff. Clearly, we will start to get information, I would hope, quite soon, and that means we can start to make some plans. In some ways, knowing the answer and then working towards it is whatever that answer might be and however difficult, is going to be important so that people do get that certainty. I think probably the other thing I would say in relation to this is that it's at time like these, and I think for many of us around the table who've been in the NHS for some time, this isn't the first time that maybe we've experienced something similar. I'm always genuinely buoyed up by the way in which our staff rise with sort of remarkable professionalism and resilience. And I think that's something which we should pay testament to, particularly given what staff have already been through over the recent past, and actually that our staff do that because they see themselves absolutely in service to the public and the patients that we serve. So we will continue to guide through these difficult times, and I know the whole board would want to support what I've said around ensuring that we are all in it together and we're supporting our staff. There was just a couple of other things I wanted to particularly raise. Although he's not here today, I wanted to pay testament to Bill Shields, our outgoing CFO. I've known Bill for many years, and I never thought I'd be in a place where I'd be Bill's chief exec. And that's been a remarkable experience in many ways. And actually what I wanted to record today for the board was just my huge gratitude that, first of all, Bill put us back on track. He really helped us to clarify where we were. He helped the system to get clarity about where we were. And he, of course, acted as interim CEO before I arrived, which I'm hugely grateful for. He's going to leave a huge hole, personality-wise, in the organisation. But I know with Kirsty, we've got a safe pair of hands to take us forward, going forward. But I will genuinely miss having Bill around. Second person I wanted to pay testament to is Judy. Judy, you played a really important part in me coming into the organisation, and I've been very grateful for your wisdom, your support in some quite difficult times early on, and you've been the organisation's sort of conscience and memory in many ways over many years, and we are going to really miss that. But I just want to record my sincere personal thanks, as well as those on behalf of the organisation, for everything you've done over many years, actually, and everything you've done for me in the last year. And Martin, although we haven't worked together for very long, I have really welcomed your astuteness, your insight, the challenge that you brought around the table, and I will miss having you with us. But thank you for everything that you've done for the board. There are other things in my paper which I'm very happy to pick up on, but those were the things I really wanted to focus on.
Thanks, Steve. Are there any questions relating to Steve's report? Okay, if not, then we will note the content of the Chief Executive's report. We can now move to item 2.3, which is the staff survey results for 2024, and I'm going to invite Piers to introduce this item. Thanks, Piers.
Yeah, thanks, Chair. So I'll take the paper as read, but it's a good segue into this from everything that Steve has just said. In many ways, we saw this as a staff survey results which were indicative of the time that we were in when staff were completing this in October and November last year. We were very much in the midst of concluding actually in the process of beginning our phase 2 part of organisational change, having had a year before that of difficult transition too. So understandably the results were disappointing. They show some improvement from the previous year, but not significant. And I think staff were very honest about providing feedback to the leadership team and the board about things that we hadn't got right and that we need to think about quickly now and going forward. So much of the report, I think, reflects the results, and so I don't intend to go through those in any significant way, other than what I've already said. There's a lot of things that we need to digest and quickly adapt to. I think more importantly, really, is where we go next. And I think the executive team felt quite strongly that this was a moment in time, and we were looking forward to a period of stabilisation over the next 12 months, and that in itself would have a significant impact on improvements to staff well-being, motivation and general satisfaction, therefore, that would be reflected in October this year, which is why the segue from what Steve said is so important, because, of course, now we know that is going to be another challenging year. We always knew it was going to be a challenging year from a financial point of view, and having to graft over a very difficult operational plan, but that is somewhat different when you have high morale and focused staff, because they feel a sense of stability, compared to what we now know will be the case, in fact, which will be another 12 months of change. And so if you look at some of the actions that we'd listed, they were written at the time when we believed that we were going to be moving into a period of stabilisation. Indeed, the focus on the executive stabilisation, so appointing 2 vacant posts in our latest executive structure, were an important feature of the actions going forward. And we've had to very quickly adapt, of course, to the recent announcements, and some of those posts will now not be filled, or will be continue to be filled in acting up in an acting up way, and some of which that Steve has already outlined. Also, in the further actions, there are other things in there that we will have to reconsider whether they will be affordable too, whereas other things will remain important. And so stabilisation, as far as we can, of the leadership team, we know is a really important feature. So we'll have to continue doing some team building, and the implementation of the organisational development plan that was presented at a previous board meeting earlier in the year will continue to be important. Investment in OD essentially will be important. One of the things that staff have fed back strongly is that they don't feel there's enough development for them, and so we were going to be looking at how we could utilise our non-pay budget to focus on some increased development opportunities. We will just have to adapt to the latest environment, and of course non-pay budget will be one of the things that we'll have to look at very seriously about how we what we spend and how we contribute to both the system financial plan, but also any further savings we or any further reductions we get to our running cost allocation. Nevertheless, it will remain important. We'll just have to adapt, and we'll have to find other creative ways of developing our staff in a more affordable way. Other things like staff values group will remain important, and those things: culture, behaviours, inclusive behaviours, and leadership behaviours that are conducive to a positive working environment will remain important, and we will continue to focus on those things. And like I say, we will do what we can to stabilise the leadership team through another period of significant change. But I think I'll stop there and just go to questions. But that gives you a flavour of what we've heard and what we're doing. And sorry, one other thing I will say is that each of the chief officers will be presenting this to their staff in their teams, and they will be coming up with their own action plans in addition to the things that I've mentioned that will be organisational wide. And we know that some directorates will need some more support because of the way the results of or what the results have shown us than others, and so we'll make sure that the OD and HR teams and others will wrap around directors and their senior leadership teams to make sure that happens. Thank you.
Thank you, Piers. Very thorough summary of the staff survey exercise. Can I invite Judy to ask a question?
I didn't want to ask a question. I wanted to say that we discussed this at the People and OD Committee. We had a special meeting to discuss it before it came to the board. I'm always cautious with these things that people don't look at the red, amber and green without really recognising that there's an awful lot of stuff underneath some of these. So if there's an area where you might be drawing conclusions, it's a good idea from the picture to talk to peers or the relevant director to understand, because different parts of the organisation were at different stages of the organisational change process at the time that people were completing this questionnaire. So it's really important with all of these, I'm not saying dismiss the results, but to be very careful with them. The other thing that I think doesn't come out quite so much in this result is in this report, there's a free text section at the end of the survey, and there were some lovely comments in the free text about the hope people had for different ways of working going forward and how they could already see that happening at the time. So although the organisation is plunged into yet another major restructuring, we assume, unless they change their mind between yesterday and what you hear next week, there is so much that has been learned about how we do this together in a supportive way by listening to the staff and what they're saying. And I think the plan includes a great deal of that. And so I just wanted to say it had been considered in detail.
Thank you, Judy. That's very helpful. Graham, please.
Well, it's a comment more than a question. I think it's really tempting to look at this and dismiss it as now irrelevant, but actually I think that'd be a grave mistake. One of the things that I certainly learned during COVID was when faced with a big challenge, organisations that were already in a good place did way better and managed to pick their way through it. So I would strongly advocate that whilst things will need to be changed, some priorities might need to be changed, that it is taken forward in some form or the other to strengthen the organisation going forward. So it's a comment, not a question.
Thank you, Graham. Kay?
Thank you, Chair. So I agree with you, Graham. There's a lot to learn from this, isn't there? And I know you'll do that, Piers. There's something for me around the L&D piece, which you picked up, and then the knowledge and skills piece. And when we understand what the purpose of an ICB is, how we can build that into helping staff very consciously think about what might be the change of purpose and what does that mean for their knowledge and skills, how do we upskill in certain areas, and how we can have that gives quite a positive thought, doesn't it, for staff going forward.
Did you want to come back on that point, Piers? Or?
No, sorry, I should have put my microphone on. I said great point. That is absolutely the right thing, and we can adapt in that way, can't we? The future purpose, which we know will be different, and we may not have all of the right skills in the organisation, but that doesn't mean to say that people can't adapt and be given those skills. So it's absolutely the right adaptation to the current environment. So thanks, Kay.
Okay, I'll invite Steve to conclude this in a moment, but Piers, I just wanted to flag up that at the People and OD Committee, we did talk about whether or not at a time of turbulence an annual survey is enough, and whether or not we do some kind of interim smaller surveys as some organisations do. We've talked about that at this board before. I just wondered if you wanted to give your current thoughts on that.
We haven't progressed it since we met. I think we met on the 19th of March, but kind of lots happened since then. But yes, I'm committed to doing that. I think that's absolutely the right thing to do. I think it was in my head and then it's gone again. A pulse. It's called a pulse survey, and other integrated care boards and other organisations do it. It's a national scheme, so we can just adopt that and implement it. I know we'll need to work with the comms team to make that happen. But thanks, Kevin.
That's good. And we'll follow that up with the People and OD Committee over the next few months. So, Steve, is there anything in conclusion that you'd like to say on this?
Yeah, well, just on that point, if I may, I'd very much support that approach so that we can keep a clear view about how staff are feeling more generally while we go through more specific discussions with them as things become clearer. I think Graham and Kay probably made my point for me, which was now more than ever, the work that we started becomes really important. I'm both pleased that we started it before these new announcements came out, but also concerned that we hadn't made as much progress as maybe if we'd started a year earlier, we'd be in a better position. So I think we've got an awful lot to do to try and get behind the organisational development plan that was previously presented here and get that sort of into the real world as quickly as possible, because that will be a key way in which we support staff going forward. So I would just absolutely support those comments that this is not something now to dismiss. This is something that we need to double down on in order to be able to support our staff.
Thank you, Steve. So is the board happy to note the content of the report and to support the next steps described? Thank you very much. Just want to note that Tandy Howard has joined the meeting, Kate Shields has joined the meeting, and that Donna Manson has left the meeting for a short time but will be returning to it later on. If we can move to section 3 of the agenda, and item 3.1 is the progress on the requirements of the NHS Oversight Framework, segment 4, and can I ask Sam Wadham-Sharp to introduce this item, please? Thanks, Sam.
Thank you, Chair. Good morning, everybody. So this is our monthly report on our progress towards achieving our exit from National Oversight Segment Level 4 in line with the newly agreed date of Q1 25-26, noting that we missed our previous date, which would have been within the previous financial year. So this paper is covering data and information for all areas for the exit criteria for January 2025, bar elective, which unfortunately remains December 24 due to the normal national reporting lags that we have within the data and our reporting cadence. However, the next version of the paper and the associated highlight report have been written, so further updates can be given if requested here today on the next month's progress. Just a note that as per normal, this paper should be read in conjunction with the associated highlight report, and that highlight report has been discussed in the February SIAG meeting with our regional colleagues. There were no proposed changes within this version of the paper to the assurance criteria. However, within the associated highlight report, there were changes proposed to the leadership criteria in totality turning to green in month for January, and the finance metric related to the submitting an agreement of a short-term finance plan for 24-25 was moved from red to amber in that particular month, and that was agreed within the SIAG. In terms of moving in for a quick overview for each of the individual criteria, so leadership remained satisfactory in month and the paper contains some detail on the refreshed assurance structures and their link to the integrated care strategy, the joint forward plan and the 10-year plan that we've heard about this morning. It also provides some detail around the Transforming Devon programme. In terms of strategy, that also remains satisfactory and provides some detail on the ongoing progress around the case for change and the fragile services that have been included within the current phase of that work. Within the actual performance information itself, UEC unfortunately remains limited assurance. Whilst improvements were seen within most metrics between December and January, there remains a significant gap between that performance and the trajectories that we submitted at the beginning of the year. There is detail in the paper provided on the 4-hour performance position for each provider and also where they rank nationally and the changes that you would have seen from December into January. The system position for December did improve to 68.1%, which was an uplift of around 3% from December, and improvements were seen in all providers. However, in that total performance, but we still remain in either the lower half in RDUH's perspective or the lower quartile for the other two trusts' perspective in terms of our national rankings at this particular point in time. In terms of the oversight framework and the improvement journey within year, I think it should be noted that in terms of the year-to-date position, UHP are now third best nationally in terms of their improvement for 4 hours in year, and Torbay are now in the top 20 in terms of national performance year-to-date in year. So I think we should be noting that around the in-year journey. In terms of ambulance handover, performance worsened unfortunately between January and December marginally, but however when you look at the corresponding figures from January 24, it's 3,000 hours fewer lost in that period between January 24 and January 25, and the February figures will improve by nearly half again, including a 7,000 ambulance handover hours lost better February 25 versus February 24. It should be noted as well that we continue to work with the long waiter protocol from region, so any ambulance now that exceeds 6 hours on a forecourt, there is a gold escalation call both internally and regionally. That will shorten as we move through the year to 4 hours and 2 hours and then down towards the 45-minute criteria. Category 2 times improved in January, but not in line with the levels that we would expect to see based on the improvements seen with an ambulance handover improvement. It should be noted that despite the levels of improvement that we've noted for ambulance handovers between January 24 and January 25. Category 2 handover times are 11 minutes worse than they were at that time last year. So there remains work ongoing between the system, SWAST and region in terms of really understanding what some of those drivers are of Category 2 response times beyond the binary look at ambulance handover positions. In terms of our elective progress for December, we've retained that as satisfactory. Torbay were the only provider in the system to meet the 78-week waiters target that was set regionally and nationally in December. UHP and RDUH narrowly missed theirs. UHP met their 65-week trajectory, however RDUH and Torbay narrowly missed theirs within the month of December. It should also be noted that whilst it's in the highlight pack but not in the paper, we continue to both exceed the national and the trajectory standards for both cancer 62-day referral to treatment and the 28-day referral to diagnosis standards, so we continue to perform exceptionally well in those particular areas. The paper does identify risks to the ongoing delivery and getting back on trajectory for long waiters by the end of March, noting that the end of March position should be 65-week waits. It is now noting that, and you will see this in the next version of the paper, those risks are to come into fruition, and we are seeing a deterioration of performance in those particular areas. However, when again we look at the levels of improvement that we've seen between December 23 and December 24 in this paper, there is a 94% improvement within 78-week waiters and a 75% improvement between the level of 65-week waiters we had in December 23 versus December 24. We also keep some of the highest clearance rates in the country, and our productivity levels are 4 times that of the national average at the moment. So I think we just need to be clear of that. That has led to us being stepped down from Tier 1 oversight. In terms of finance, I won't go into this in any detail because there is a separate finance section, but the year-to-date position for January was in line with the plan for the system. That was reforecast in month 8, and there is detail within the paper around the efficiency savings to date and the levels of recurrent savings versus non-recurrent that are required to deliver the plan. So in terms of an overview, that's that, and we're asking the board to agree the assurance ratings within the paper and to consider if assurance can be taken from the ongoing plans and delivery that we're seeing within year. I'm happy to take any questions.
Thanks for that very comprehensive summary of the NOFRO report, Sam. Are there any questions for Sam? Kay, please.
Thank you, Chair, and thank you, Sam. A really good run through. Could I, as a new non-exec member, could I understand the satisfactory assurance around elective? So when I think what I'm understanding this to tell us is that we haven't met the long waiter trajectory in all providers, and in some providers we won't meet it by the end of the year. And I wondered if the assessment was very binary, so we either meet it or we don't. And so I'm slightly concerned that we talk about revising trajectories, but I can understand why we do that during the year, but by March it doesn't have to be 0. And then I wondered about the ERF and whether that, the Elective Recovery Fund, whether that gave us an opportunity to improve that.
That's a really good question, and it's one that we've been working with Region on through the year. If you look at the wording of the criteria, it talks about virtual elimination within some of the long waiting criteria, and the oversight framework itself is based on month improvement. So when we've discussed the satisfactory assurance rating, firstly, I think we need to be mindful this is looking back to a December position and based around the conversations that we had with our providers in their locality meetings within the month of January, and they are still pushing to get back to the 0s at that particular point in time. So we were taking reassurance as well as some assurance from that. I think when we then go into the conversations that we have on a weekly basis with Region around the long waiter positions in tiering and the noted levels around productivity, the clearance rates still remaining incredibly high, the conversations we're having with Region are that they are satisfied with the work that is being done within elective, and I think there would be a different conversation to have if we didn't hit the 0s at that particular point in time. I'm mindful Alison's here, and also Sam, who's chair of the Elective Improvement Board, who might want to give their own view on that. But we've been looking at it from a month-on-month improvement basis, and noting that this paper has been through the SIAG where there wasn't any challenge in terms of our green rating at that particular point in time. I think we might want to take some consideration as we move forward, as we are now moving further away from trajectories as we get into January and February, plus the risks related to planning for next year would be a different conversation. But at the point in time of this paper, satisfactory felt like the right assurance level to give.
Thanks, Sam. So the challenge there is whether or not the board is happy to accept a satisfactory assurance around this. Perhaps I could bring in Alison. Well, let's bring in Sam first and then bring in Alison. Thank you, Sam.
So, Kay, as Sam says, some of this comes back to definition. So we will not hit the 0 and 0 on 65 and 78, but we're in regular conversation with the region about what is an acceptable tolerance. And currently we are on trajectory to hit the acceptable tolerance, if that makes sense. I'm only wording it like that because there's always a little bit of grey about the definition of acceptable tolerance, but I think that's broadly where we are.
Alison.
Thank you, Chair. And Richard Schofield may want to add to this as well. I think the whole intent of the oversight framework is about the extent of improvement rather than necessarily a binary did you or did you not hit the target on the nose. I think the exception to that might be on finance, but I think for the others there is a degree of tolerance, as Sam says. And I think that it's very clear when you look across many of the domains within the NOF4 framework, there is clear evidence of improvement throughout the year. And part of the expectation in the SIAG meeting next week is to receive feedback from the chief executives of the self-assessments of the boards about where they believe they are in respect of the NOF4 exit criteria. And the timing of this is quite important because we don't know at the moment what the new oversight framework is going to look like. All we do know is that there is going to be a new oversight framework and that may come into being before the end of Q1, in which case is Devon then assessed against the old framework in terms of exiting NOF4, or is that abandoned and an assessment is made against a new framework? And we don't know that at the moment. So the advice that has been given is that we continue almost until apprehended, and that we continue to undertake the assessments with a view to there being a final judgment probably in May and a recommendation up to the National Committee in June about the position of Devon in terms of its escalation status. So all of this becomes very important, particularly when we start to look at the end of year data. So on electives specifically, we're looking at December data at the moment. The March data will be critical. And some of the indications are that there may be a deterioration between the forecast in December and where it ultimately lands in March. But again, does that land still within the tolerance? I think the UEC position is probably fairly clear, but there has been significant improvement, and in fact UHP has been one of the most improved areas in UEC performance across the country, yet it's still quite a long way from where it needs to be. So there's going to be an element of judgment and measurement in making these recommendations. But it's coming to a bit of a crescendo really, and that position in March will be critical. The other thing just that we don't know at the moment, but I think we need to almost close down 1 year and one process before you enter another, and that is what next year's plan will do for everybody in terms of their position around performance. But I think the current position, I would agree with the assessment that Sam has presented to the board. And as I said, the March position will be really critical in terms of determining the NOF4 status going forward. I don't know if Richard wanted to add anything to that, Chair.
Is there anything you'd like to add, Richard?
No, thanks, Kevin. I think that was a really good summary, Alison. And I think just to go back to Kay's point around some of the metrics, the idea of the oversight framework is to evaluate not just hard metric achievement, but also do we have confidence in the improvement journey? Because the oversight framework is a transition from one phase to another. And so some of the elective work, and indeed some of the UEC work in Devon, whilst it won't achieve all the metric objectives likely by the end of March, in some areas we have seen we would take real confidence from the approach that's been taken compared to other systems in the country who've improved less quickly. But I also take the point from Alison that everything now will be determined by the end of year position and the plan for 25-6. But I'm very comfortable with the validated data that was presented in December representing satisfactory progress up to that point.
Thank you, Richard. Steve?
Yeah, it was just to come in on that point, I guess just to acknowledge for the board, as much as I would love to have clear blue water between the old NOF 4 and the assessment of that coming out of 24-5 and 25-6, I think it's probably very likely that there's going to be a bit of a mixed position, and it will therefore depend as much on our plan going into 25-26 around confidence, at least, that thing that's difficult to measure, but is really important to how systems are perceived. How we land that plan, I think, is going to be really key, if not entirely clear, in the assessment about our NOF status or whatever follows.
Thanks, Steve. Alison?
Chair, I agree with that, Steve. What I think is also important is that there is some formal closure and an acknowledgement of all the progress that has been made. And I think that's really important for all of the people who have worked so very hard. And irrespective of what the new regime will bring, as the Improvement Director, I feel a real sense of responsibility to provide that report which recognises all of that progress as a landing point, and that will be done as soon as we have the year-end information.
Thanks, Alison. Sam?
I just think Alison makes a really good point, and I know we're all very worried about 25-26, but if you stand back and look at 24-25, we've delivered our financial plan. The majority of systems haven't. We are making significant progress on UEC and elective. So actually, we do need to say well done to our teams because they've done a fantastic job under quite difficult circumstances.
Thanks, Sam. We fully endorse that. Let me just summarise what I've just heard on the question that Kay asked some time ago, which is that I think that what I'm hearing is that the NOF 4 exit criteria is not a binary calculation. It's about the extent of improvement over a period of time, and that I'm hearing that we're recommended to maintain the elective assurance as satisfactory on the grounds that we think, on the data that we have at the moment, that it will land within the acceptable tolerance of that. So, Kay, are you happy with that response to your question?
Yes, thank you, Chair. Really helpful conversation. Thank you.
Thank you. Are there any other questions for Sam on the NOF 4 report? So, if not, can we agree the assurance ratings relating to the achievement of each of the NOF 4 exit criteria, which are as follows? Strategy, satisfactory. Leadership, satisfactory assurance. UEC is the only limited assurance, and we have satisfactory assurance for both elective and finance. Are we happy to agree those ratings? Thank you very much. And then can we take assurance that adequate plans are in place to mitigate the risks relating to the delivery of NOF 4 exit identified in locality planning and delivery meetings and system leadership group? Thank you very much. We take assurance from that. And let's just also note Alison's point that we are looking to have a formal acknowledgement of the progress throughout 24-25 of all of the work of many teams across the system on NOF 4 exit. Thank you. We now move to section 4 of the agenda, which is for approval or endorsement, and the first section of this is on NHS Devon strategic intent. There are 3 elements to this: the 5-year forward plan, the 25-26 annual plan, and the 25-26 operational plan. I'm going to ask the Chief Executive to take us into this item. Thanks, Steve.
Yeah, thank you, Chair. And there's an awful lot of detail in here which I don't plan to walk you through. I'll probably make two observations up front. The first is, as a board, we recognise that we've been involved in many of these discussions over the last few months, and actually a lot of this detail has been tested and developed with board members around the table. And I think that's both useful in terms of seeing what you've seen today, but also I think a step change in the way that this board has been able to work and to be able to spend its time thinking both about the sort of 5-year view and indeed the plans going into next year. And I think that's something which I think is a positive step forward, particularly when we link it to the previous discussion around not for exit leadership and so on. So that's I think a positive. I know board members will recognise much, if not all, that is in here, because, as I say, we have had a significant amount of time together. I'm going to try and take them as a whole, and I'm going to try and just plot out what is quite a complicated set of things and how they work together, because we have a number of different things that we have to do which are set down for us as requirements and things that we need to do locally and how we run the business, and actually trying to join those things up into one sensible narrative about how the medium term links to the immediate term, I think is quite important. So the first thing here is the joint forward plan refresh. This was a light touch refresh for all sorts of reasons this year, but nonetheless a really important document for us, because this in effect is the ICB strategy in response to the wider integrated care partnership strategy involving all of our partners, and sets out over the next 5 years what it is that the health system needs to do. That's a piece of work that, whilst it's been light touch this year, we're keen in the first 2 quarters of next year that we do a full refresh of that, so we end up with a very clear health and care strategy, including a clinical strategy, which will sit within the ICP strategy. Our annual plan is our 1-year detailed delivery plans in relation to what we're trying to do over the next 5 years, and it's therefore our response to that, and it includes the actions that the ICB is taking in relation to the operating plan as well, which sits below it, with a particular provider focus, and in particular an acute provider focus, so they're not exclusively. The annual plan also sets out those steps that we're taking to prepare for the future. So alongside the response to the JFP and our response to the operating plan, it sets out, in particular, that thing I've mentioned, the development of an ICB health and care strategy over the coming months. And then finally, the operating plan, as I've already said, is largely an acute focus plan with some elements of mental health, which sets out how our providers are committing to the requirements in the performance framework. We've been on a rapid journey around how we do planning within this organisation, so you will see within the annual plan, I hope, a further step forward from where we were last year, which in itself I think was an improvement. We've got a short number of objectives that we're trying to hit, 17 in total. All of those objectives have an executive lead assigned to them. There are a set of plans that sit underneath them which are very granular in terms of what, by when and who. And many of them, if not all of them, requires cross-organisational working, and is a response really to feedback that I had very early on here, which we felt quite siloed as an organisation. So the execs taking the lead for these have a responsibility to make sure they got the right people around the table, and that isn't necessarily from within their own teams. But it's important for the board to know who it is around the table that you need to look at in relation to that, but recognise that these are team objectives that we are all working together on. And we've also, importantly, through the work that Philip has done, routed all these through our revised governance framework. So there's a clear link into each of our assurance committees, so that the board can rely on that process to provide assurance both on the veracity of the plans as they stand at the beginning of the year, and the assurance around delivery of those plans in year, so that we as a board can be both assured and also spend time considering the strategic issues that we need to consider and making sure we have time to do both. I'm happy, Chair, I know there's a lot of detail in there to take any questions on any of the detail in there, but hopefully that's a helpful overview.
Thanks, Steve. Is it worth taking questions on each section of this at a time, or do you want sections on the whole?
I think rather bravely, I'll take questions on the whole, so who knows where we might go, but it might be easier.
Okay, thanks. Let's proceed in that way then. Are there any questions for Steve? Kay.
Thank you, Chair. So when I was reading the documentation, one of the things was really good and it clearly hangs together. The thing I was thinking to myself is we know Devon is significantly over target in terms of its distance from target and its fair share of national allocation. And what I was struggling with was to understand whether the strategy that we're putting in place will solve that over target position. And so there's something for me about quantifying, trying to quantify at a very broad level the scope of the financial changes we might expect from our strategy. Because there's something for me about, finance doesn't exist on its own. It's not a thing. It's just a consequence of the decisions we make. And I can't see how those decisions at the moment will lead to us becoming sustainable within our fair share of national allocations.
Yeah, a really good question. So the annual plan at the moment reflects simply the things we're going to be doing in year in relation to the short-term actions. The development of the strategy needs to address precisely that issue. And of course, we developed a medium-term financial plan last October, which we presented to NHS England, which set out how we were going to get back to financial balance, including the distance from target, including dealing with the convergence over that time period. Clearly, as a result of all the work currently going on to land the 25-26 plan, that will need to be revised, and that will be done alongside and as part of the strategy development work, which we'll do in the first 2 quarters. So we should be able to describe the landing pathway to get back to clinical and financial sustainability over a period of time.
Thanks, Steve. Thanks, Kay. Alison.
There's a huge amount of work gone into this, and it's so much better, and a lot clearer. That there is a slight but. That the but is almost seeing the wood for the trees, because there's so much in here. And I'm mindful of the conversations earlier about staff, and we're relying on huge discretionary effort from staff at a time when it's going to be even more difficult to rely on that. So I suppose the question is, how do you prioritise in the context of the uncertainty and potential sort of significant changes in the profile of staff, and how are the real key strategic messages from here influencing the work of the providers, the provider collaboratives, so that there's a real clear steer. These are the 5 things that we're all lined up behind. Now, it may be that comes out through the strategy work that Peter's doing, but it feels like that is going to become even more important going into next year, that absolute clarity and then lining up of all of the other parts of the system to help deliver it become even more important. So that's not a criticism. It's more a question at a point in time that the sands are moving again, aren't they? And that need for real clarity of purpose and priority, particularly for the acute trusts and the out-of-hospital services, how that could be distilled from here. And I kind of almost don't expect the answer, Steve. It's almost a rhetorical question, but I hope I've made myself clear.
Yeah, I mean, and again, a really good question. I guess the first thing to say is that these papers were written before we knew some of that uncertainty. But also in regard to that, board members will recall last year, whilst the plan was in a better place, there was still something like 120 priorities in it, and we've got it down to 17. So there has been a bit of, in the context of not before pre-announcement, the organisation trying to be really honest with itself about what it is that we could deliver and trying to really hone it down into those things and to deal with that issue around matrix working so we get the best out of everybody in the organisation. So to an extent we've done some of that, but of course the uncertainty is now greater. I think you're right. The work we need to do around the strategy over the next few months really needs to harness the work of the collaboratives, particularly PAPC, the acute collaborative, but all of them in general. And we need to ensure that they are part of the vehicle by which we deliver that strategy, but also given the uncertainty and the potential reductions in ICBs, that they do some of the heavy lifting in terms of delivering on that for us, because we simply won't have the staff. So I see those things, that they're very much live. These papers probably don't reflect that reality. So in some ways, yeah, I don't have an answer for you other than I acknowledge the challenge, made some progress, but actually we've got to really think about that. If I've got any sort of meta worry next year when I'm looking over and above the details of our plan, it's going to be one of bandwidth to be able to do everything that we need to do, and that's the bit that we need to absolutely address.
Was it on this point that you wanted to come in, Peter? Let me invite Peter to come in on this point then.
Thank you. I think Alison and Steve have said most of what I wanted to say. I guess my own reflection would be, if we're going to do a strategy properly, we have to do a discovery phase so we can all imagine what those priorities should be. And I think that part of our job is to reflect the priorities that our population require to the people who are considering the strategy, and then revisit at the end of that how we reprioritise based on that work. And that, I think, is the work that Steve is leading us to do. And my second reflection is that bit about prioritisation, because it's easy to say, isn't it? It is easy to tell our teams to prioritise and then go, and what about all the things that we told you not to prioritise? What's happening to them? I think there's a real important piece of leadership behaviour work that needs to go alongside this, that helps us empower our teams to not do the stuff that we're telling them to deprioritise. And certainly the discussions that I've been having with my team focus as much on that as they do on working out what the priorities are.
Do you want to just come back then, Alison? Thank you.
Very briefly. All the mood music, if you read the journal and everything at the moment, is almost sort of indicating the strengthening of the role of commissioning in the future, and being really clear about the strategic role of the ICBs to set that strategic intent and be very clear about its commissioning priorities. And as you say, it's for the collaboratives to go away and work out how they do that, and working with the providers then to deliver it. So I think that focus will change. This sets you up well for that, but perhaps the pace is going to have to be even faster than you imagine.
Yeah, we note the point on pace, Alison. And Sam, is it on this point before I bring other people in?
I mean, I think Alison makes a really good point. So whilst I absolutely recognise Steve's point that we're going to have a real challenge as an ICB with less resources, I think we're going to have a really, really important role about setting out what the healthcare offer is going to be. And I don't think we can just assume we can leave the providers to get on with it, because history would suggest they will come up with the wrong answer. I can say that as a provider.
Thank you. Some helpful observations. So I've got Frank, Graham, Kate and Lopa in that order. So Frank first, please.
So one comment and two questions. The comment is really to say Alison and Sam's point about complimenting the staff on what they've done this year was raised previously, and thank you to John Taylor and Libby Ryan Davies for actually putting it all into the JFP. It is in there now, saying what the achievements have been, so that I think is a really important addition. The two questions, one is very specific and one is more general. We are at a point in time, but we have had to put a pause on some of the appointments. The Chief Primary Care Partnership and Place Officer is supposed to be leading on 6 of the 17 objectives for next year. And also the Primary Care Collaborative has really struggled to find which meetings they should attend. So the question would be, can we consider how you, if that appointment cannot go ahead, how the collaborative can get into the right meetings at the right time? And the other very specific one was page 215, which is about community-based care and support delivery. It says out of scope is hospital-based care models. Can someone assure me that does not include virtual wards? Because clearly virtual wards are although run by the hospitals at the moment in Devon, are very much community-based issue.
On that second issue, yeah, I think we can provide that assurance, Frank. It doesn't include, this was about within the acute footprint, really, not within the virtual ward footprint. On the first point, yeah, so we have postponed on that post for obvious reasons. I'm hoping that we will have an answer to how we're going to move forward with that really quickly. I don't know what that answer is yet, but it's something I need to resolve urgently for the reasons you've said. In the meantime, the work is going on anyway in the absence of that post being appointed to. And I guess my more general point, we absolutely want to work with a collaborative, so we do need to invite them in because we can't do all this of ourselves. So we'll take that conversation offline, Frank, about how we can make sure that those frustrations are dealt with.
Thanks, Frank. Thanks, Steve. Graham.
Thanks. Yes, 2 points. One, building on some of the conversations we've already had, which is about resourcing capacity. I mean, I think one of the deficiencies I've perpetually seen is plans that don't have resource estimates against them, either in people or monetary terms. And thus it's very hard to assess the deliverability of it. And then if you start overlaying into it this question about limited bandwidth and prioritisation, which is a far more nuanced thing than doing things or not doing them, you don't have a currency to really do that. So I think we do have an issue about understanding resource implications and thus the doability, and therefore where when we have to change things, which I think we will, how do we go about that? So that's point number one. I think just reinforcing conversations we've already had. The second point is that there's an allocation of these two committees, which I think is new in terms of some of those responsibilities. And I think, Philippa, you and I have had a bit of a conversation about this, but I think we just need to make sure that in the forward business plans of each committee, it is very clear which committee is looking after which one of these objectives to provide that governance oversight, especially as we move forward and have to make some perhaps quite difficult decisions. Thanks.
Thanks, Graham. Steve, do you want to respond to the first point?
Yeah, just on the first point. So I think there's two elements. That the annual plan for the ICB, we did in developing them, we were clear on both of those points, and that's partly how we've managed to hone down the priorities, because it was a very honest discussion about, are you expecting any investment here, and does that investment exist? If not, we can't do it. And secondly, do we have enough capacity within the teams to be able to do it? So whilst that's never perfect, and we were in this room with all bits of paper all over the wall, developing it with the teams, I think it is in a better alignment. I think the second point, though, which I think we just need to acknowledge, in reference to everything we need to do as a system next year, particularly in relation to landing the plan, the 25-26 plan, there is an awful lot of work to do that sits in the operating plan section of this. And I think for now, we've still got to do to have a proper look at through the system leadership group whether we've got the capacity to do all of those things, and if not, where are we going to focus our time? That's something I'm bringing to the system leadership group meeting in April, so that we can ensure that we've squared that, given we've been on a bit of a moving platform over the last couple of weeks.
Thanks, Stephen. And Philippa, could you respond to Graham's second question, please?
Yes, thank you. So I think Graham's absolutely right that we will need to nail this down very quickly. For me, I think it's almost it's a further point on from Graham's point, which is which of these do we think we need to have joint committee consideration of? I think we can have one committee allocated to each, but there will be certain objectives that require a quality and a finance perspective. There will be some which require a population health and a quality perspective. So I think there's a quick piece of work that needs to be done to make sure that that's addressed as well. What we intend to do, and talks to the final piece of this pack, which is the board assurance framework and the approach to thinking about the risks to the achievement of these objectives, is work with the committees over the coming couple of months before the next board meeting to look at the milestones that are in each of the objectives to make sure that the committees have those in their forward plans, but also that we're really clear about what we think the risk to those will be, so that we can make sure that we are getting the right level of assurance into the right committees as well. So I anticipate that that work will be done through the committees in the next couple of meeting cycles.
Thanks, Philippa. Graham, is there anything you want to come back on that? If not, I guess the thing that I just wanted to check, Steve, is I guess what you can't see from this is what we're not doing and the impact of that. So it's also kind of a negative question, really. But I just wonder if at some point, I don't think this should stop the approval of this today, but at some point we just need to get an understanding of that as a board in terms of the risks that are inherent in what there isn't enough money to do, the risks that are inherent in what we've deprioritised. That's the bit that we can't see. So, and obviously that could be an encyclopedia-size exercise, couldn't it? And it's not what I'm asking for, but I just wondered if we could get a sense of that at the board and to understand whether anything out of that needs to find its way into our risk processes.
Yeah, I think let's think about how we do that. As you say, it could be a huge exercise or relatively small. I think we just need to think about how best to do that in a way. Broadly, we can draw a straight line between the JFP 5-year stuff and what we're doing next year. I think the nuance is in how much progress you make in 1 year against those things, and that's where we've been trying to. It isn't necessarily about not doing things, it's about not doing things maybe as fast as we would like. But we'll try and think about how we can do that in a way that's really clear for the board, so you can see where we're making most haste and where we aren't.
Thanks, Steve. That's really helpful. Let's capture that as an action to bring forward to a future meeting. So can I now invite Kate Shields, Chief Executive of Cornwall and Isles of Scilly ICB. Hello, Kate.
Hi, Kevin. Thank you. So I just wanted to build a bit on what Alison was saying. So we've all worked very much as our own individual ICBs and pulling our plans together, but our people who we serve have largely got the same needs, but need them meeting in slightly different ways because of where they live. So I do want to see whether it be something that we could bring our teams together really early on in April to look at the plans that we've got rolling out between us and across us, and maybe to get some not joint working, but joint sharing. We know we're going to be hearing news over the next week or so, and I think Alison's right that we might need to move faster than any of us are individually planning to do. So I just wondered whether we could align our plans, share what we're doing that's non-institutional, that's around population and place focus, and perhaps use that way as binding us together so that as we're moving through changes, our staff are moving through it together.
Yeah, thank you, Kate. Really helpful suggestion. We've re-established, as you know, the Peninsula Strategic Group that you and I lead. I suggest we bring our plans to there, and we'll have a detailed look through, because there will be synergies in that as well, and there may be things that we can go further and faster on if we work together. So, very happy to do that, and let's use that structure.
Thank you, Kate. Thanks, Steve. And finally, on this item, Lopa, please.
Thank you. It was just as a new INEM, it was just a matter of perspective that I wanted to share with you, in the sense that I find this quite odd. We have a 5-year plan, and then we have an annual plan, and then we have an operational plan. And I'm wondering, in terms of time frame, where the mid-level's gone. So what I normally am used to is a 10-year plan, a 3-year plan, and an annual plan. That's kind of what I work to. And the reason for that is that obviously we cannot deliver things within a year. but then neither we can deliver in between a year and the 5 year. And so I just reframe that. I know that the NHS works in different ways, and I understand that, but I feel we're doing too much short-term focus and not enough of that strategic focus. It's back to issues about tactics versus strategy.
Yeah, I think, again, a really important reflection. It's useful to get your outside view, because sometimes we can get into, well, we just get used to the way the NHS works. Some of the things that we're having to do because we are required to do them. I entirely agree that, I mean, we will have a 10-year plan from the work that's going on in NHS England at some point. I would be very keen to move us, if we could, to a 3-year plan, because 5 years feels too long and 1 year feels too short. I think the history of Devon, and we are not out of it yet, and this doesn't signal that we're going to get out of it in the foreseeable future, but the development of a strategy will help with this, is that we are still very much in the tactics. We've got so many things to do tactically to sort of to keep the system, or get the system where it needs to. But I think the challenge for the board, for the ICB over the next year, is to try and carve out some of that space to think not just into 26, 27, but the 2 years beyond that as well, so that we can plot a bit more of a course. Clearly, this is all in the context of the massive uncertainty that we're currently dealing with, but to reflect Alison's point, if the role of ICBs is going to be anything, it looks fairly certain it's going to be about strategic commissioning. And I think you can only do that broadly in the 10, the 3 and the 1 year timeframe. So I'm hoping we will move towards that.
Thank you, Steve. If there's no further questions, then shall we move to the recommendation? So we're asked to approve One Devon's updated 5-year joint forward plan. Are we happy to approve the JFP? Thank you, that's approved. We're asked to agree the proposal to begin rapid development of NHS Devon Health and Care Strategy, which will form the foundation of the 5-year joint forward plan to be updated next year. Do we agree? Thank you very much. We're asked to approve NHS Devon's 25-26 annual plan. We approve the annual plan. We're asked to note the update provided in respect of 25-26 operational plan. Thank you. We're asked to approve the proposed approach to articulation of the board assurance framework in 25-26. Are we happy to approve that approach? And finally, we're asked to approve the proposed approach to the articulation of the risk appetite statement for 25-26. Are we happy to approve that? Thank you very much, and thank you for all of the massive amount of work which has gone on and continues to go on the planning process. Thank you for your leadership on that, Steve. We move to 4.2 now, which is the review of the NHS Devon Corporate Governance Framework, and I'll invite Philippa to introduce this item. Thanks, Philippa.
Thank you. Vying with Steve in terms of the level of content associated with this cover report, for which I apologise. But I think it's a really important point in time. I think it's important for boards to make sure that they can regularly consider their corporate governance framework to make sure that they are appropriate. And there have been a number of issues that we have been able to pick up and address through the corporate governance review this year. We don't anticipate that we'll be quite as many documents in future years, but I think just going through the general content of all the appendices of the report, board members will be aware that we've had some discussions around the NHS Devon Constitution for some time, and this represents the culmination of the proposed amendments to the Constitution. This isn't a decision that is within the gift of NHS Devon to approve. What we have to do is ask for approval from NHS England. We still think that it's appropriate and have consulted with NHS England to go ahead with this approach whilst we have this period of uncertainty, because the nature of the changes that we are seeking are quite key. Part of the constitutional requirements is that we have a corporate governance handbook, and one of the things that I've always wanted to achieve with the corporate governance handbook is make it something that actually helps people understand what corporate governance is and how it works to enable an organisation to work. So I think we've tried to achieve that with that handbook. And of course we have our key policies that sit and underpin all those strategic documents. having undertaken recent reviews of the scheme of reservation, delegation and understanding financial instructions, we're not proposing to amend those at this point, but they are included for completeness. And the Executive Committee has delegated authority to approve any amendments to the operational scheme of delegation, so that will be taken to the NHS Devon exec. Included in this, for the sake of completeness, are the reviews that have gone through each of our board assurance committees and proposed minor amendments to those terms of reference. The report also includes the proposed committee membership for 25-26 and information about the progress made against the governance improvement plan in 24-25 and the 25-26 governance improvement plan. As part of this work, we've also sought assurance from our internal audit colleagues to ensure that we are taking an appropriate approach. Unfortunately, we haven't been able to colleagues haven't been able to complete the work in advance of the board meeting, but I have had correspondence and confirmation this morning from our internal audit colleagues that they expect to complete very soon, and they have not identified any significant issues that they would anticipate wishing to bring to the board's attention in relation to this as well. I think, given the nature of the detail that's associated with all these documents, I would suggest that there's a slight amendment made to the approvals, if granted, that any detailed amendments coming out of a detailed review of these documents are approved through the appropriate committee with the chair and chief executive, and if there's a terms of reference amendment, it goes through the chair of that committee as well.
Thank you, Philippa. How do you want to take questions on this? Do you want to take questions on the whole, or is it? Yeah, okay.
Happy to go on the whole. Yeah.
Let's go from the whole. Any questions for Philippa on the governance documents? Salma.
Questions, Chair, but I thought both of these were really good documents and really helpful from an induction point of view, actually, because they set out how we do business, the different kind of arrangements in place, and it was a really easy kind of follow-through guide, if I can just use that word for a moment. There were a couple of things I picked up on the Constitution, which are not material things, just spellings and just one or two things missing, which I've said I'll give to Philippa rather than take the time up here. And there was one or two areas where the People and Organisational Development Committee meeting was missing, but there was a REMCOM meeting, so that might be my understanding of how the committees are organised. So again, I'll just kind of send through where I picked that up, which pages I've picked that up, just for clarification.
Thank you. And I think we addressed the people, and I think those are included in the appendices that were formally appointed to the board. Board members had the opportunity to review all the detailed documents before they were circulated as part of the board back, given the level of information included. So I think hopefully that's been addressed, because they should be there, and they have been through the People and OD committee as well. I think. Thank you. So yes. Detailed comments from Salma, and Lopa has also provided a number of detailed comments that I think it would be helpful to reflect. I don't think they're of the nature that requires a significant discussion at the board, which is why I think it would be helpful if we could just have that additional delegation of authority to undertake to make those changes with the chair and chief executive.
Thanks, Philippa. Lopa.
Thank you. There is only one area I think that I would like to raise, if I can today, which is around the policy relating to fraud, bribery and corruption. And I think that does need to be addressed, which is that we need to be aware that there is the new Procurement Act, and therefore I'd suggested maybe the fraud element needs to be taken out and specifically included as a separate issue, and then that would go through audit and risk for approval, I guess. Thank you.
Thank you. Yes, so I propose that we have a discussion with our local counter-fraud specialists to make sure that they're content with the proposed approach. I see no reason why there would be any concern, and then take it back through the Audit and Risk Committee to make sure that there's appropriate assurance there before we bring it to the Chair and Chief Executive for approval.
Thank you, Philippa. So I've got Kay and then Judy. Kay, please.
Thank you, Chair. Can I just test out? And I've been through it all, and I think it's a really full and very clear set of documentations. What I couldn't quite spot was how the specialised Services Committee fits in with the Devon governance. And it's just my lack of understanding. I expect Philippa, but if you could help me with that, that'd be great.
Thank you. So I've made a reference to it in the governance handbook to demonstrate the supra ICB arrangements that are in place. So the delegation, which will be coming, I think it was the next item on the board, once that's approved, we will have that delegated authority in place. We'll take the delegation agreement in place, which sets out the detail of the role of the committee through that. So there'll be then a report back through from that committee up to this board through the executive committee, the NHS Devon executive. So happy to clarify that one as well.
Thanks, Kay. Thanks, Philippa. Judy, please.
Just for clarity, Philippa, my understanding going forward is that NHS Devon Remuneration Committee will not be dealing with internal workforce issues like it used to in the past, but that actually the People and OD Committee is going to have a part 2 when issues relevant, like the staff survey, are picked up. But on page 11, which is of the report, page 281, it still says the NHS Devon and Internal ICB Workforce Committee. I think that was the past, not the future. Is that right?
Until this committee is named in the Constitution, and has the proposed amendment in the Constitution. But until the Constitution is amended, we can't amend the name of the committee.
Okay, but as a group, everyone understands their roles. My apologies. I thought we could change it once we went into next year. Sorry.
Thanks, Judy. Thanks, Philippa. Any other questions for Philippa? Lopa.
Sorry, it's just a point of clarification. The handbook, where does the responsibility lie for the... So with the board rather than with the committee? Right, thank you.
Thanks for that clarification. Okay, shall we move to the actions? So we are asked to approve the proposed amendments to the following essential documents from NHS Devon Corporate Governance Framework. They are the NHS Devon Constitution, including the standing orders at Annex A. And they are the Corporate Governance Handbook and the key policies at Annex E. And just for clarification, Philippa, we now submit the Constitution for approval to NHS England?
Yes, there's a formal process to be gone through for constitutional amendments. We have completed, with the approval of the board, the first 3 parts of that. The final part is the submission to NHS England. So there's a submission to be undertaken. We consulted on it with our partners. So we include that information in there as well. And we have already shared the proposed amendments informally with our colleagues, and they've confirmed that they have no significant concerns, but they still have to go through their formal processes as well.
Thanks, Philippa. So we're also asked to approve that no amendments should be made to the following essential documents from the NHS Devon Corporate Governance Framework. Those documents are the Scheme of Reservation and Delegation at Annex C, the Standing Financial Instructions at Annex D. Are we happy to approve that no amendments be made to those documents? Thank you, we approve that. We're asked to note that the operational scheme of delegation has been reviewed and will be presented to the NHS Devon Executive for approval at its meeting on the 1st of April 2025. We're asked to approve the proposed amendments to the terms of reference of the board's committees and committee membership in 25-26, which is Annex F in the documentation. Are we happy to approve that? We're asked to take satisfactory assurance from the progress made against the governance improvement plan in 24-25. Do we take satisfactory assurance? Thank you. We're asked to approve the governance improvement plan for 25-26, which is set out at Annex G of the paper. Thank you, we approve that. And we're asked to note the proposed terms of reference for the NHS Devon Commissioning Group and to take assurance from the information provided with regard to how the functions previously discharged by the Primary Care Commissioning Transition Committee will be fulfilled via executive structures in the future, and that's outlined as Annex H in the paper. Thank you. And Can we just thank Philippa and team? This is an extraordinary amount of work which has taken many, many months, and it just feels really good to have got to this point where we can bring this to the board. So can we just note in the minutes our thanks to the governance team and everyone else who's been working on it. Thank you very much. We now move on to item 4.3, which is the specialised commissioning delegation arrangements. And I invite Lou Higgins to introduce this item. Thanks, Lou.
Thank you very much, Chair. I'm going to presume that everybody's read the papers in your documents, and this is the culmination of almost 2 years of work that John Finn and his team have been working on. So it's with his greatest apologies that he's not here today to present this, because this is a really successful piece of work, and I'm hoping that we're going to seek your approval across the board today. This was first brought to this board in September 2023, and this is part of the national plan to delegate the commissioning authority for specialist commissioning from NHS England to ICBs through a regional approach and model. And this will take effect from the 1st of April, which won't go unnoticed, that's only next week. It just so happens that the timing of this board for our ICB means that we are the last ICB to be submitting our responses, which you'll see within the papers, and the other 6 ICBs within the South West region have already approved that delegation to their ICBs. So it's with great import that we ensure that we've really covered this off today and hopefully get your approval. The paper itself and the various documents that support the approach that we're taking in Devon as an ICB have been through rigorous review from the experts across governance within our contracting team, looking at our information governance included, and there is unanimous support for this approach that you'll see set out in your papers. The benefits, I think, is a really important part for you to be looking at within the paper in terms of the benefits to our community and why a delegated approach, a more localised approach, is going to provide a better experience of care through the numerous amounts of different specialised commissioning that we have that will be delegated to our authority, which will include local decision-making, enhanced coordination of care, much more aligned to a population health model of delivery, and improved patient outcomes, which have been evidenced. So the ask of the board today is to accept the delegation of SpecCom and to approve the approach within the papers around the arrangements to support this. Happy to take any questions.
Thank you, Lou. Any questions for Lou? Phil, please, and then Graham.
Thanks. It's not so much a question for Lou, but I just want to bring to the board's attention that DPT, Devon Partnership Trust, is the lead provider for the specialist mental health services currently commissioned directly to us by NHS England. And therefore, the sort of changing governance arrangements means that sort of affects that. So it doesn't affect anything about the board's decision making, but I think it's important to know that there is a provider in this ICS that's the lead provider for the SpecCom services for mental health.
Thanks, Phil. And Graham, please.
Thanks. I was interested in the sentence that says that we would take on responsibility for it, but accountability would rest still with NHS England. And the fact that those two are separate, I think, is an issue. That said, given what we know that DHSE and NHS England will merge together, I think we have to prepare ourselves for the fact we will also, in time, most likely become accountable as well. Is that your anticipation?
Thank you. So the paper and all the work that's gone in to this, to the approach, has obviously been done before the announcements. And I think that it's incumbent upon us to be able to act on what we know today, but as you say, with a view to what may be likely consequences of the arrangements for NHS England. What we will be doing, though, is not standing alone as Devon. We'll be working with the other 6 ICBs, not just within the South West region, but also from a national point of view and looking at what the options are around that and what that means around accountability for the delegated authority, not just the responsibility. And we've got clear governance arrangements around everything that we've been doing over the last 2 years to get to this point that will continue until we have a better understanding of what that means.
Thanks, Graham. Thanks, Lou. Sam.
So I'm fully supportive of the proposal, Lou. I just think going forward we need to have a more strategic conversation as a board about what we want out of specialised commissioning. So if I look at it from a patient perspective, there are still far too many patients having to travel to London to get treatment. So as part of this, we do need to think about strategically how do we repatriate some of that activity into the region and do that in partnership with our specialised commissioning colleagues.
Thanks, Sam. That's a really good point. Do you want to come back on this?
Yeah, just to say, I mean, I guess there is the opportunity now, Sam, to do that with these changes. And again, having referred to it before, if we are the strategic commissioner, then how we strategically commission specialist services is going to be a really key part of our function. So I absolutely agree. And I think there is a lot we can do to improve the experience for patients in the peninsula.
Okay, can I bring in Martin and then Kay?
Thanks, Kevin. Yeah, supportive of the decision we're making. I suppose I just wanted to touch on the risk briefly, and particularly financial risk is mentioned, and rightly or wrongly, I always associate specialists with expensive. But I wasn't completely clear whether, I suppose, indirectly we suffer the same risk anyway at the moment, given that if resources are used in NHSE, perhaps we don't get as much coming back here. So perhaps it's neutral. We're just do we have, I suppose, with the things we've just mentioned around bringing people back from London, changing services slightly, the possibility to either mitigate the risks or indeed, turn them into a benefit, I suppose, if we can change how we commission specialist services locally.
Thanks, Martin. And do you want to respond to that, Lou, or shall I bring Kay in and then we can respond to both?
Yeah, bringing Kay in first.
Yeah, Kay.
Thanks, Jan. Just bringing in some of my knowledge from the work with the Specialised Services Committee. So the committee is now working on strategy, and so obviously Devon is part of that. So there's something about let's feed all this into the strategy that's currently being developed. And in terms of risk, the risk is quite interesting, isn't it? Because in our current commissioning environment and current contracting environment, we're in the position where the risk almost is with the provider, and therefore it's with the system that hosts that provider, because we don't have, with very few exceptions, we don't have any cost per case type contracting between specialised commissioning and providers anymore. So the extent to which Plymouth and RD&E and DPT are specialist providers, we've already got that in our system. Of course, when you then take a population look at it, we need to think about where our population goes to access specialised services. So it's just a bit of a reflection on where the risk is.
Thanks, Kay. That's helpful. And Judy, please.
I just wanted, Lou, assurance for the committee that the lessons from the delegated commissioning from pharmacy, optical and dental pod services had been learned. I believe John was focusing on this, but it isn't just the commissioning, it's the whole kind of local population now comes to us about these services, so impact for the patient experience staff and others, and quite a steep learning curve, certainly for all of us on the dental side, but perhaps on some of these other specialties too.
Lou?
Yeah, I can provide that assurance, Judy. John's absolutely been focused on that. His team itself has been taking that learning, but also we've had the opportunity through this process over the 2 years to apply a lot more strategic thinking, and then with partners in that space as well, in our 6 neighbouring ICBs particularly, and through the governance arrangements and the strategic thinking through Kay's group. I feel that we've managed to ensure that we've mitigated some of the risks that we've learned through before.
Thanks, Lou. And have Tandy, please.
I'm fully supportive of this, and I think it'll give us a really good way of continuing to work in a population health level, given that we know our population much better than others would. And not that this tend to be 100 services that are still with NHSE, and I'm sort of just wanting your thoughts on, aligning and as well as comms in terms of the public understanding these sorts of things that we know in the background, but the public don't really understand very well, as well as whether there's any sort of health inequalities linked in terms of us, sort of taking over these particular other services to remain with them, and whether there's some risk there.
Thanks, Tandy. Do you want to respond to whether there's risk there, Lou?
I don't know whether there's any risk there, but there is bound to be impact of different health inequalities upon the numerous services that we're talking about. So that's an answer that I can seek for you and provide some clarity after the meeting, if that's okay.
Yeah.
Thanks, Lou. Any other questions on the Specialist Services Delegation? So we're asked to approve the acceptance of delegated specialised commissioning responsibility from NHS England and the proposed arrangements to support this delegation. Are we happy to approve that? Thank you. And let's note the flagging up that it would be good for us to have a more strategic conversation about specialist services commissioning, and let's find the right timing to do that once we have the 10-year plan, probably. Thanks very much, and I'd like can we thank John for all his work on this, and we thank Lou and the team for their work on it. It's really good to see this this landed at this point. It's been we've been working on this for quite some time, haven't we? So it's really good to see it landing here today. Thank you. We move on to item 4.4, which is NHS Devon finances and equity. So board members will remember that this has been again a report that has been worked on for quite some time. I would just remind members that part of the instigation for this work has come from Plymouth City Council, and we should just note that Mary is the chair of the Plymouth Health and Wellbeing Board, but that we've looked at whether or not we think there's a conflict of interest, and we don't think there is in view of Mary not being a voting member of the board. So with that introduction, I'll hand over to Kirsty to take us into the paper. Thanks, Kirsty.
Thanks, Chair. I'm conscious that some of the newer board members may not have been on this journey with us. So just to give a little bit of background, we've been working out equity of how we allocate resources for many years, and the sort of starting point of this query and this analysis was back in about 2014, where the analysis showed that Plymouth were not actually receiving their fair share of the funding for their population. So what we need to note here is that there are two ways of looking at this. So there's what we call relative equity, which is contractually how Devon allocates its resources based on need. And then there's consumption equity. Now, the consumption equity includes all of the expenditure. So it includes anything that we're funded over our fair shares on the target, and also it includes all the deficits. So it's about the cost base rather than the allocation base. So there is a difference between the two, and we need to appreciate that. So based on the work that was done, and there was recognition that Plymouth locality was underfunded, there was a transaction of about 5 million that was carried out a few years ago, and a commitment to continue to do this work to see how we could get everybody to within a certain tolerance on the funding. What the latest updates are in this paper are for the 23-24 outturn and the 24-25 plan. So it's been done on that basis, and this shows that the recent analysis shows that South and West are now consuming materially more than their fair share. North Devon are not far off their fair share, and the East are under-consuming. So it has changed over those years, but obviously during those years the formulas changed, the expenditure profiles changed, there's lots of changes, but this shows that over time that equity position, which was traditionally assumed, has actually almost flipped the other way. We've also calculated what we think will happen over time. So obviously there's a process for us to try and get everybody back to break even, and also we have to pay convergence every year to get ourselves back to our actual allocation formula. And when we've modelled that, then we think that over time the equity will shift so that Plymouth will no longer be underfunded or overfunded, and that the main area will be in Torbay, it will be over-consuming compared to East, which will be the ones which are under-consuming. So what the proposal here is that we continue to do these updates so that we have this position, so we don't lose sight of it, but that until we've really done that recovery process and understand the recovery plan for Torbay and the impact that will have, that we shouldn't make any allocation or resource adjustments because of the information that's in here going forward. But I think we do need to continue to update it, and I think we also need to think, is the time now right, or will it be right to, rather than be thinking about what goes in and out of the different acute settings, more around the shift from acute to community and primary care, so looking at the shift to the need to go into the community rather than across organisations. So that in a nutshell is where we are on equity.
Thanks, Kirsty. And that last point around this becomes more about how we spend the money. I'd just like to ask Steve to add the developments, particularly in Plymouth, around that issue. Thanks, Steve.
Yeah, thank you, Chair. And I think we have absolutely been on a bit of a journey with this. Some might argue a saga with this. This has been a real concern for our colleagues in Plymouth City Council, and the work that's been done, firstly, has been done with an eye to ensuring that we're being really clear and open book with them about what the issues are. And of course, these things, there is always art in how you do these things. It's never quite black and white. But this paper was shared, and there was an opportunity for feedback and change from our colleagues in the council. So I think reflects a fair view about where we think we are. I guess the second point I would make before going on to where we are, how we're going to take this forward, is we absolutely as a board need to be cognizant of how the money shares out across the big system of Devon, but we're not just simply an allocator of resources into the system. We've got a much more active role, and that will sometimes mean that we choose to direct our resources in a way that would be different than the simple equity analysis might show. Of course, we need to justify that, and we need to ensure we're clear about why. And then the third point being that whilst we can be clear about how we're trying to allocate money, clearly where overspends and financial challenges are landing is somewhat different from that. But there is a correlation, I would argue, maybe not direct and one-to-one, between some of the pressures we see financially in our provision system and some of the wider challenges for the patients and the populations in those areas. There's a demographic and age profile piece to this. I've had a number of conversations with the Chief Executive Council, all really constructive. For me, the next stage of this, we've established a round table with our colleagues from PCC, with Tracy and I there, to explore actually what the key question is for me here, which is how do we shift left from where we are at the moment, which is, to put it simply, and this is not entirely, there's more nuance than this, but we have a significant acute overspend. How do we shift left in a way that enables us to significantly reduce that overhead by, of course, moving into community prevention, population health, all of the things that need to be in our strategy. And linked to that, a conversation with the council about how we can revitalise the local care partnership arrangements, so that actually that can do a lot of the driving work on this, because particularly our council colleagues and our locality teams, they understand things on the ground much more clearly. So this for me is part of the efforts I think that we've started with the ICB to be clear about what it is that we're trying to achieve through the strategy we're developing, but then devolve how it gets achieved out into our locality so we can empower our teams and our local authorities to do that. So that will be the source of the conversation that we have. We now have the benefits of the locality-based Discover report, which is looking at all of the comprehensive opportunities for out-of-hospital care. That will clearly be part of this. And we have the opportunity around, if I can see a deficit as an opportunity, the opportunity to try and redirect some of that money that is tied up in the wrong part of the system, probably treating people in ways that are less than optimal, in a way that actually benefits the people of Plymouth. And I would just say, of course, we want to do exactly the same work with all of the other localities as well. So it isn't that we're doing this just in Plymouth, but this is where we're going to try and get started and really test some of this. Happy to take any questions.
Thanks, Steve. So are there any questions for Steve and Kirsty? So I've got Phil and then Sam and then Kay.
Thank you. So it's not about any of the numbers. It's about process, because we've just rehearsed the history of a set of numbers that suggest a set of outcomes, and that was the Plymouth bit, and it's led to a load of revisions. So my question is, in the numbers coming to us in the revised form they have today, what has been the scrutiny of that amongst system partners and within the governance structure of the ICB, such that we're looking at a set of numbers we're confident in?
So I don't think it's been out particularly to the providers, but the basis on which it's been done has had independent scrutiny over the years. So Carnell Farrer did a review of it. When we first set up the methodology, it was chaired by someone from Exeter University, and then we had PSC come in and do an independent review, because I think there were questions on whether it had been done appropriately and fairly. And so PSC did that review and confirmed the methodology was correct. So what's in here is just an update of the figures using exactly the same methodology. So I don't know if that gives you the assurance you wanted, Phil.
Yeah, it does. I was just curious about that. I think you set that out. And has this been to the ICB Finance Committee, for example, to be reviewed? That
It's not been to the Finance Committee, but it has been to the Executive Committee. Yeah, several times.
Yeah, thanks, thanks, Phil. Thanks, Kirsty. So, Sam.
So if we step back from this as a strategic commissioner, we've got a responsibility to ensure we're delivering equity of service provision and equity of resource allocation, haven't we? And we could have a long debate about what equity means, which in the world of ACRA they have done for decades. But Steve, I absolutely agree with you. We need to be thinking about this as a place-based conversation that aligns to the left shift, and that's our mentality on this. The thing that makes me nervous is that first recommendation about no specific adjustments to the distribution of resources based on this analysis. I think we are where we are for 25-26, but what's coming down the track nationally from 26-27 is a much more direct link of you have to get to fair shares allocation. And I don't think we can sit here then as Devon and say we won't cascade that down to the localities. So I think for 26-27, we do have to be saying we've got to be moving the localities closer to fair shares.
Yeah, I think that's a fair point. Probably this recommendation is more a reflection of a short-term recommendation, not what our strategic intent ought to be over time. So perhaps we could reflect that in the recommendation that this is about the immediate here and now.
Thanks, thanks, Sam. So I've got Kay, Frank, and Lou. So Kay first, please.
Thank you, Chair. So a couple of points from me, more clarification, I think. So the first thing to think about is what do we mean by target, and what tolerance is there around that? So, nationally, the tolerance is deemed to be sort of 2.5%. So in other words, once you get that close to target, you're within the realms of, uncertainty, I suppose. Now, of course, the smaller the population we look at, the greater that realm of uncertainty becomes. So I'd encourage us to to decide before we get there, because it's always easier to decide before you get there rather than argue once you've got there, what we think a tolerance is on a locality-based target. So in other words, does it need to be more than 2 and 2.5%? Because once you get to smaller populations, it's more variable. So I would encourage us to do that work now rather than later. And then the other point is that I don't know actually whether there's specialised commissioning allocations in here or not. No. So there's specialised commissioning 320 million. Almost inevitably, that won't be on the fair shares basis, and it could significantly impact on what we currently think the locality-based distance from target is. So I think we need to rerun it with specialised commissioning in there.
So on specialist commissioning, we don't have the data at GP practice level, which is how this is all formalised. It's all the commissioning's done at a provider level rather than on a population basis. Once we get delegated, we may have access to more information that will allow us to do more on the specialist, but that has been excluded from this at the moment.
So there's something for me about that. The ICB does have a baseline for specialised commissioning, because you've got a target and a baseline. And so you're right, Kirsty, we need to understand how that baseline is being constructed, and the regional specialised commissioning finance team will be able to help with that. I don't know the details, as you'd said, is it practice or not? It won't be practice for everything, definitely. Yeah.
So I think on this point, probably Steve wants to come in and Phil would like to come in. So Steve.
As he was on the tolerance point, I don't disagree. And of course, the smaller the population base, the more noisy the data, and probably we do have those conversations up front. I just want to guard us against. Because these things can become all consuming in both trying to set tolerances and then understand them and get the data and update it and so on, that we don't end up becoming a sort of acrolite in all of this. I think this needs to be seen as a diagnostic, and probably broadly in the round, what's it telling us about whether we're spending our money equitably across organisations. And the broad messages here is that when you look at it on a consumption basis, actually we are probably spending too much in the wrong places, but therefore that gives us opportunities. But there are issues in Eastern which seem to stick out, which we need to understand a little better about why it appears that we are spending less than you would expect for that population. So I think we need to use it as part of our diagnostic tools to be indicative and to ask questions, and then to think about how we respond to that in our strategic commissioning sort of environment. Because I can just imagine we could set up an industry otherwise.
Yeah, thanks, Stephen. Phil, on this point, I think as well.
It was on the SpecCom one, which obviously is a really good one to raise, and I think is for outside the room. I mean, I'd express a view that actually, is it worth putting it down at locality level, given specialist services usually work at a higher population level across boundaries? But that's a debate for the future, isn't it?
Yeah, thanks, thanks, Phil. So I've got Frank and then Lou, and then we probably need to summarise where we've got to on this. Frank.
So it was on a similar sort of point that I think I understand that it's not part of it, that tertiary referral centre in UHP is not part of these costs as the basis. The other thing is, I think this is a really, really important paper to get the whole of Devon providers on the same page as we go forward. We're going to have to make some really big strategic commissioning decisions. And I have been attending a primary care meeting in Plymouth where they're still quoting the 2015 figures and genuinely believe that they are underfunded in terms of fair shares. So how are we going to get all the providers, all the collaboratives informed about this so that they can be taken on the journey for the big strategic decisions we're going to have to make?
Thank you, Frank. The communication of this and understanding of it across the system, really important point. Steve or Kirsty?
Yeah, well, I think I just take the point, Frank. We need to feed this into our strategic discussions, this development of this strategy and how we engage with all of the collaboratives. I was just thinking about the point, even say if we took the Plymouth system being 9.2% above. If you're sat in primary care, it doesn't feel like you're overfunded. Because that's not the reality of it. So it's also needing to be clear about what this means and what it doesn't mean for different parts of the health system. And therein lies the challenge about how do you make that work in a world where we've got to try and shift money around the system. And that's the strategic challenge we face.
Thanks. Is it on this point, Mary? Yep.
Just to say, don't forget, we've now got the spectre of local government reorganisation coming into all of this. So the figures that you've got for various places within Devon are going to be changing. So that's something else that needs to come into the melting pot.
Yeah, absolutely. Thanks, Mary. And finally on this then, Lou?
Thank you. I'll be really quick. I just wanted to welcome the final recommendation in the paper around tasking local care partnerships to do the work around reducing the demand for secondary care. But I would go one step further and say we should make mention that the neighbourhood health service model is the way to do that, and that needs to be absolutely part of our strategic thinking in this space. Thank you.
Thanks, Lou. So let's try and summarise where we've got to. So we are asked to agree that no specific adjustments to the distribution of resources based on this analysis are made until the recovery programme for southern locality is understood and impact assessed. And I think what I've heard from the meeting is that we perhaps narrow that to a 25-26 recommendation. Which kind of merges into the second recommendation that we should continue to update and monitor this as part of the objective for equitable improvement of access and reduction of health inequalities. And I think we've heard in the meeting today the clear links between that exercise and our commissioning role as an ICB, the strategic commissioning role, specialist services commissioning, the link to convergence agenda, given that we are an ICB which is funded above the fair share allocation target, and other impacts on this will be the local government reorganisation and our emphasis on neighbourhood health. So if we just add that in for clarification to those two recommendations, is everybody happy with the first two? We then, as just referenced by Lou, we're asked to agree that as the system works through recovery and the provider deficits are eradicated, the focus should shift towards targeting strategic equity provision by rebalancing health spend between acute, mental health, primary care and community services, and this should be reinforced through the introduction of a key priority for locality care partnerships to reduce secondary care consumption by identifying better value services in prevention, population health and community primary care services. I don't think there was a full stop in all of that, was there? Are we happy to agree that final recommendation? Thank you very much. Okay, so we've now reached a point of a short break for 10 minutes, and if we could resume the meeting at around 12:15, that would be helpful. Thank you very much, everybody. Thank you. Okay, welcome back, everybody. We're now into section 5 of the agenda, which is the Governor's Performance and Assurance Report. So, as we did last time, I'm proposing that we take items 5.1, 5.2 and 5.3 together. So I'll first invite Penny to present the quality report and the Torbay Joint Targeted Area Inspection Closure Report. And then I'm going to invite Tandy to report from the Quality Committee of the 13th of March, where both of these items were considered. And then I'll open up questions on all three reports at that point. So can I invite you, Penny, to take us into the first report?
Thank you, Chair. So as you say, these were had prior consideration at the Quality Patient Experience Committee, and to note that our new non-executives attended that committee and provided some helpful feedback. So I will take it that the report is read. I am unapologetic, actually, about the breadth and depth of the current quality report, because the journey we've been on is really restating the position of quality within this board agenda. It's been in place now a year and will be subject to review at year end, and will be truncated and in some ways replaced with a quality dashboard. The development of the quality dashboard is in line with national developments. So Devon ICB is a member of the National Quality Strategy Group that has been convened. And the reason that national group has been convened at this very difficult time is to make sure we do not lose sight of quality during a major reorganisation. So I feel really positive about that, and then we will have really like a national through to service delivery line of sight. At the meeting I attended yesterday, which I stepped away from for our board, I had the privilege of hearing Penny Dash speak, and obviously we would not want to repeat or give an insight as to her report in the next couple of weeks, but there is one key message I want this board to hear, which is about holding the line on quality and quality management through the line. There are a huge number of external agencies with view on quality, but actually the role of the ICB and providers are absolutely key. So that's all positioning for my report. So in terms of the report in front of you, I, as I say, assume that you have read the summary report. I want to draw your attention to the quality focus of in urgent emergency care. It's so important that in line of a number of publications that have come from National, that we actually actively protect and oversee quality in really difficult circumstances. So things like ambulance waits. There's been a piece of work that we've undertaken in relation to dynamic risk assessments. That's how do we understand the clinical risk along the line, and thank you for Peter for working. We're working together on that. We are doing well against key other national requirements, such as the Patient Incident Response Framework, which replaces the Serious Incident Framework, with all the pros and cons of that, and we're currently working that through. But all of our providers are fully compliant, as are we. And then there's a safeguarding component, which I'll cover off in the JTI report. I want to bring particular focus to vaccination, so it's a new part of the report this year or this month, and that's to really shine a light on the importance of vaccinations as part of our winter pressures. But actually there's a vaccination optimisation strategy that is far beyond winter. We do relatively well benchmarking, but it's not good enough, actually. We really need to be thinking far more about our staff vaccinations, and we are covering that off in our winter wash-up. And it does make me think about when you benchmark, we're doing better than, but what is that benchmark and what do we need to do? And we're doing quite a lot of work of understanding vaccine hesitancy in our own staff, and it's very much related to seniority, and age. The other area I want to draw your attention to that isn't in the summary report but is in the main body and actually has developed since this reporting period, which is February, is that we're convening a maternity summit, April 3rd, and that is to respond to the receipt of now all of the diagnostics for our providers relating to the National Maternity Safety Support Programme. And that's a really key summit because the cost of delivering on some of those recommendations is large. I won't say prohibitive, but it certainly needs to be considered in the context of our current financial situation. And so the summit is to bring together those things that can be done in provider without our involvement, cost neutral, could have cost benefit, as well as clinical benefit. Those things that can be done with system involvement with limited costs by better coordination. And then those things that really are going to provide a significant financial pressure. And then what does that mean in terms of our past work? But of course, how we mitigate the risk in the interim is a really key point. And without wanting to be too verbose, I think this really illustrates where the ICB can add value in our system delivery. And of course, it is an area of real public concern, maternity, nationally. So I'll go now, if it's okay, Chair, into the Joint Targeted Area Inspection. So the JTI is, I don't know if any of you, but if all of you really understand a JTI. So it's really looking at our multi-agency delivery of the Care Act obligations, as in 89, but joint inspection from Ofsted, from CQC and Her Majesty's Inspectorate for the Police, Fire and other emergency services. So they take a particular view on the efficacy of our children's safeguarding partnerships, which does include our lead safeguarding partnerships, Steve, but also has a slightly broader remit in that it looks at those children in need and very often early help. So we were named as the principal authority on this because in the inspection, as of November 23, it was mainly health failings that needed to be responded to. And in practice, that is clinical curiosity by our clinicians. It also looked at clinical curiosity, professional curiosity throughout the partnership, and also some lessons around governance. So by being named as principal authority, it's really important that this board is cited on that work and is equally satisfied to progress as the regulatory area for oversight, which is the partnership board. So I've been working with the independent scrutineer for the partnership board, who we benefit from his independence, and he has helped inform the position in front of you today. But all but one of the action areas are now closed, but we do not remain satisfied with that. We really are progressing this because professional curiosity can be measured at a point in time. It's an area that needs ongoing focus, especially with staff changes, with, one of the areas was our front door, our A&E departments. And so we're holding a workshop in October to keep this as a key area of focus. And that will be subject to ongoing audit. I'll pause there.
Thanks, Penny. So before we open up for questions, I'd like to just hear from the Chair of the Quality and Patient Experience Committee, Tandy Hara, as these issues were discussed at the last meeting of the committee. Tandy, are you? Can I invite you to present your report? Thank you.
Thank you very much, Chair. And can I just start by reinforcing the positioning that Penny has said in terms of the importance of quality. Obviously, what we've discussed up to date, whether it's regarding finances or workforce changes, all of that has direct impacts on quality. And with the changes, the quality agenda is going to be quite important indeed. So in the last committee, we had a deep dive around elective care with particular focus on driving improvements around that. We do have some concerns around the increase in people added to the waiting list, and in particular the effect of this on young people. Obviously, a wait of 1 year in a child's life is very long, and the impact can be quite devastating as that child grows older. And so we have some concern around this slow pace of recovery of these waiting lists, in particular for young people. For that reason, we will have another look at this issue. We've requested a follow-on paper to come to the committee. The reason being we need to understand it more about the arrangements around that, but also to make sure that the impact of long waits is a focus at the locality meeting. And that issue is also going to be discussed in the system quality group, so it's assured with what we're doing there, as well as the issue of patient choice and how that might affect health inequalities. We also did look at the quality report, which Penny has just covered it comprehensively, so I'm not going to talk too much about that. Apart from that, we did note some improvement in the initial health assessment data. We still do have some concern around the mortality data and their levels, but we've asked for that to be investigated a little bit further, just to be sure that those sort of data, it's not to do with coding or anything that we need to be informed about. So we've got that, our sights on that issue. We also looked at the system quality group report. We're really pleased with the development at the system quality group, in particular the addition of local authorities to that. That gives us extra assurance about our grip on issues of equality, systems of quality. We have the annual plan as well, and looked at the diversity objectives for autism. That again, that's an issue that's been ongoing in terms of those objectives not being met. But we want to sort of let that out of our sight. Another issue is around clinical effectiveness. There's an issue there in terms of risk with sort of prescriptions being made externally and the impact of that on patients and GPs. But again, it's an issue that what I execs and of the members will look at offline and then come back to the committee to see if we need to do anything more on that. Apart from that, I think that's all I needed to add to this report. Thank you.
Thanks, Tandy. Very good summary of the meeting. So I'll now open up the meeting to questions on the quality report, on the JTAI closure report, and on the report of the chair of the Quality and Patient Experience Committee. Julie, please.
Thank you very much, and thank you to Penny and to Tandy for the growing information we have and understanding we have on the quality issues. It's soared in the time you've been with us. Can I just check what you said about vaccine hesitancy? And I think you said that it's related to seniority and age, and I wondered if that was in the staff. And the reason I'm asking the question is that in the People and OD Committee, when we were looking at sickness levels in our system, this issue of vaccine hesitancy came up, and it seems to me quite an important one to do something on early on, because leadership and older people being pro-vaccine and supporting younger people and encouraging people, it's a kind of big issue for our staff, for sustaining our services for our patients. And it's one of those ones that spreads nastily if it's... So was that what you were saying, that our seniors...
Yes, and that's based on some national research that has been led through Mark Radford at the national team. And what we need to make sure is that is generalisable to our local population. But it's something that we are including in the winter wash-up, but we need to do it in a different way. And what I'm really pleased about is how Piers and I are working together, because there's the sort of soft controls, and we do really recognise, and it'd be interesting, Sam and Phil, from a provider perspective, that any reflections you've got, but numerous amount of mobile vaccination opportunities and so forth. But sometimes it can be as simple as actually having some type of cup of coffee as an incentive or an opportunity to properly rest. People really feel concerned about leaving the workplace to go and have their vaccination on occasion if they're very busy. So it's going to be multifactorial, but I think the soft controls, but also we do need to be looking at the people, the slightly harder controls around, you know, being safe at work. And you'll be really well aware of all the issues last year around the NMC and, you know, where we were looking to almost enforce it. We need to be really active in the space.
Would you like to come in on that point, Salma?
Add to Penny's comments, really. I think everywhere nationally has struggled with this. It's not an issue that's isolated to Devon. There are new models coming through around peer vaccination teams and going to the workplace rather than expecting people to come away from the workplace, and hit teams, question answer sessions, a whole range of things, as you say, Penny, between some of the softer stuff and some of the kind of the harder edge, incentivising teams and those sorts of things. So there's probably some learning across the board that we could draw on, but it is an issue that's quite difficult because ultimately we can't direct people to have it. The best we can do is to try and make sure that they are aware of all of the information. There's an opportunity to do myth busting, etc., etc.
Thanks, Sam. So I've got Sam and then I've got Mary. Sam, please.
So just on that vaccination point, as you say, Penny, we do comparatively quite well, but there's a long way for us still to go, isn't there? And like everywhere in the country, rates have dropped off and we need to do something about that for next winter. My point was just going to be, I was going to pick up on what you were saying at the beginning about quality, and I suppose I've articulated it a little bit different in my organisation in that I've said we have to be crystal clear that we have to hold the line on safety, but we recognise some aspects of experience we're not going to be able to address in the coming year. And I just think we need to be upfront and honest about that because our resources are more limited.
I really welcome that. So some of my feedback to some of the initial documents nationally, which was sort of still the old and still relevant in many cases, the Darcy work, which was about improving, continuous improvement. I actually put maintaining and understanding, and about how we have clinical risk tolerance in the same way as we do wider risk tolerance, and that needs to be discussions at board in light of the unitary obligations of board, and I think that's the real world we are living in.
Thanks, Penny. Thanks, Sam. So I've got Mary, Phil, Tandy and Alison. So Mary first, please. Thank you.
Well, it'll be interesting to see how the spring COVID response goes, because the window was open this week, and certainly going on the Plymouth site, there's quite a few places that are offering it as a community spaces rather than, I mean, Dear Road, Argyle, everybody go, you know, they all know they can go there. But I think that's going to be interesting to see how this one goes, because there is still a lot of COVID around. People are still having friends, family and that going. So whether that's enough to, you know, sort of incentivise people, we'll wait and see.
Very well made, and it may be an area that we want to have some board seminar work on about the broader vaccination optimisation piece.
Thanks, Penny. Good suggestions. Let's move to Phil, please.
Thanks. I just want to sort of pick up on what Sam was saying there, and I think we really do need to talk about the different aspects of quality, don't we? So safety, efficacy and experience are the three things I think about, and having an open and honest dialogue about each of those aspects. That is not to say that absolutely safety, yes, is a bottom up. That's not to say that experience and efficacy aren't important, because they are. And intellectually, a lot of people will argue all those things are linked anyway and you can't separate them. But I think having that component part conversation when we are looking at difficult choices is better than just using the phrase quality.
I would probably argue effectiveness is key, because if we're not clinically effective, what's the point. Keeping people safe is do no harm, but we do also need to deliver effective care. But I think that's the debate we need, and I think the Penny Dash report will provide exactly this opportunity to have this conversation. It seems like a very sensible way forward, and it's certainly something I think we would need a board response to some of those recommendations, but we probably need to see it and build a session, perhaps through QPEC.
Thanks, Penny. So have Tandy next, please.
Yeah, it's really just add to exactly the same point, and I totally agree with all those points that have been made, except to add that actually this debate, like Penny has just said, this is the right time for us to have it as a board, but I think that we also need to start thinking about how do we package it for the public to be able to understand what we mean by that and not to be confused, because I do think that this particular elements of care that are no longer possible in this climate that were completely given 2, 3, 4 years ago, and elements of the public who still expect that standard. I think we need to put ourselves in a space where we're frank and honest about the things that are now possible, things that are no longer possible, not because they're not important, but because the climate has changed. And I think that sometimes managing expectations, especially at public level, is also quite important, so they understand what we're doing and why we're not doing certain things, and that certain things are not all lumped in as quality when actually not.
Thanks, Tandy. Peter, do you want to respond to that? Thank you.
Yeah, I think other people have said most of what needs to be said. I guess my observation around safety even is what is safe, what's safe enough. We all drive a car, we all get on a plane. There isn't a zero impact on doing that. And so how do we have that dialogue? And I think particularly with clinicians and particularly with acute secondary care clinicians about how, you know, some of the hard yards we will have to do as a system will be about, I think, bringing our clinicians along with that journey that says what is safe enough and allows us to provide other services that currently we can't.
Thanks, Peter. So I'll ask Alison to come in and just some, and then Selma, and then perhaps some final comments from Steve. So Alison, please.
Thank you. Can I just say well done on the JTI report. I remember when the inspection landed, and it was a real concern to this board and to the provider boards. So I can only imagine the hard work that's gone into to get to that place. My question was on the CHC report. Does that include the Torbay information?
So, such a good question. It does.
Right.
So those quality indicators is a one Devon position. Within that, there is variation, and that's the work we're doing now to unbundle.
Thank you.
Okay, thanks. And Selma?
Yeah, I think most of them have already been raised. I just wanted to say that I think some of the environment we're in or about to go in bears some similar resemblances to what happened around the Mid-Staffordshire and the subsequent inquiry. And the Francis report did actually publish a set of learning and recommendations that I think have been drawn upon, and the National Quality Board and the board oversight documents and stuff have captured those. So in many ways we're in a different position now in terms of the learning and the tools that we might deploy, which I think puts us at advantage. But I think the one thing that we need to focus on is leadership. I think it's about the leadership and the courage to have the conversations beyond quality is important. It's about what do we actually mean by it, how do you manage risk and those sorts of things, and distributing that leadership through whether it's a ward environment, whether it's a board setting such as this one, or Sam in your organisation, etc. But it is about actually having the courage and also the integrity to kind of hold true to quality, because unfortunately sometimes it's the first thing that tends to slip, and we all know this, and it's just about putting building blocks in place to draw us back should that kind of pressure allow events to run.
Thanks, Selma. Penny, and then I'll bring Steve in.
Yeah. So thank you, Selma. And the CQC components of quality are the DARSI, patient experience, clinical effectiveness, safety, but inclusive of leadership. And I think we might expect to see that in our forthcoming publications. And incumbent on all of us. Thank you.
Thanks, Penny. And finally to Steve.
Yeah, actually, just to respond on that point, I think that's a really salient point given the challenges that we know the whole system faces, and knowing that the chasing of one particular element of performance can have all sorts of quite serious consequences for patients. I think it reflects about some of the discussion here. I'm really delighted to see how far we've come in starting to put quality much more at the heart of what we do with Penny's leadership. That's not where we were a year ago, and clearly we will all feel this, but we need to keep the focus on that. And I think in the medium term, when we talked earlier around strategic commissioning, Penny and I have talked about that this needs to be strategic commissioning for quality and outcomes rather than just for widgets going into the system. So we need to be really clear about that, and we need to be really clear about what the inevitable trade-offs are. And for me, part of quality, just to add to everybody else's, is accessibility, and we need to understand how we trade off these things, and that links right back to where this board started today, which is, and that needs to be a conversation with our public about what that looks like and what those trade-offs, what is acceptable, as well as with our clinicians. So it's really important, and I think again, I wish we were 10 years further forward, but thank God we've done the work that we have done, because it's put us in a good place. The only other point I wanted to make, which Alison slightly stole my thunder on, but I remember when I started, the J-type being issued with us being the responding authority was a very rare event, and there was a huge amount of concern about that. And I know when I first started, that was probably the first thing you talked to me about when I walked in. The work that you've done to get us to the point where we can now close this, I think, is really remarkable. As you've said, as you've mentioned, ensuring that recognising this is never a done job, particularly around maintaining professional curiosity. We do need to think about how we continue to monitor that and ensure that we don't slip back, so that we don't ever get into this situation again. But I know you're on that. But I just wanted to commend the work that you've done with the council, with the provider, to actually take something which was really unusual and get us to the point so quickly where we can close it down.
Thank you, Chair, and it would be wrong for me not to reflect the role of the team in doing that, but thank you.
Thanks, Penny. Okay, can we move to the actions then? So we're asked on the quality report, we're asked to note the assurance level relating to the quality position of the ICS as satisfactory, and to support the position that adequate plans are in place to mitigate and improve quality risks. Are we happy to note that? On the JTI closure, we're asked to take satisfactory assurance from the progress of the Torbay Joint Targeted Area Inspection Action Plan and the future governance and monitoring arrangements through the Torbay Safeguarding Children Partnership. Are we happy to take satisfactory assurance? Thank you. And on the Chair's report from the Quality and Patient Experience Committee, are we happy to take assurance from the report of the Chair of the Committee? Thank you very much. We now move to the finance reports for month 10, and just as we did for the quality reporting, I'm going to take the finance reports at 5.4 and 5 together, as those finance reports were considered by the Finance and Performance Committee on the 12th of March. So I'll ask Kirsty first of all to present the finance reports, and then Martin to present his report from the committee, and then I'll open up for questions. Kirsty.
Thanks, Chair. So I'll just take the reports as read, and as Kevin said, we had quite a debate around these at the Finance Committee. These are the month 10 reports, but in fact we're only 4 days away from the end of the financial year. Obviously we're getting to the point of the year where we make final decisions, and things should stabilise in terms of risks and those sort of things. The only thing that's moved in month 10 across all of the reports, so the ICB and for the system, is the risk position, in that we have flagged and then had a subsequent discussion at the Finance Committee in March, which is in the Chair's report, risk around whether the ICB should use the reserves that it set aside to help balance the system to actually deal with some of the pressures across the system, which is what the original plan was, and whether we should revert to the original plan. So that was a discussion that we had in the Finance Committee in March, following the risk that was highlighted in this report. All other things still remain the same. The areas where there's not complete assurance is on efficiencies, and that's not because we've not delivered them, because we've actually overachieved efficiencies, but we haven't delivered them at the correct rate of recurrency, which has therefore had an impact on our underlying position and has flowed into the 25-26 position. But otherwise, we're suggesting satisfactory assurance on the finances.
Thank you, Kirsty. Martin, can we have your report from the Finance and Performance Committee?
Yes, thanks, Kevin. There's actually two reports in here, one from February month 9 report, which is pretty historical now, but the only substantive item probably to highlight there is that we were proposing approval of a business case to do with shared finance service across Devon, which subsequently went to the main board in private, but has been approved to go forwards. In respect of March month 10, we spent quite a lot of time, as usual, going through the NOF4 criteria. We've already covered that at length today, so I won't dwell on it. Looked at the month 10 figures and were able to take assurance on the position that we had. I think it's fair to say, as described, we had a big discussion around, the risks crystallising towards the year end and how we should reflect those in the projection. And the opinion of the committee was that we should really take a prudent view. If there were going to be risks, let's not leave it until month 12 for that to fall out of the position. Let's move the position slightly earlier if we feel we need to. So gave the support to the finance team to do that when necessary. We had a good discussion actually around the plan for next year. So starting to look at the first cut of that, which has moved on since, but a particular discussion really around what the finance committee's role might be in the next year and what sort of assurances we might be able to draw on and give to the board. So quite a lot of focus on, whole-time equivalent changes, controls around staffing, SIP, being recurrent, non-recurrent, and how we really make sure that, the grip the organisations and the ICB have got, is scrutinised by the committee and therefore is able to give assurance to the board. I think that was probably the key things, Kevin.
Thank you, Martin. So any questions for Kirsty and Martin? Okay, if not, then we are asked to take satisfactory assurance from the information provided with regard to the NHS Devon financial position as at the period ended 31st of January 2025. Are we happy to take satisfactory assurance? Thank you. We're also asked to agree the overall assurance level relating to the financial position of the One Devon integrated care system of satisfactory, and that adequate plans are in place to mitigate the risk relating to the delivery of planned savings and efficiencies into the management of the financial risks identified at plan stage. Are we happy to take satisfactory assurance? Thank you very much. On the Chair's report, we're asked to take assurance from the reports of the Chair of the Financial and Performance Committee and note the escalations for information contained in the report of the meeting held on the 12th of February 2025 in respect of the One Devon Finance Shared Service, the importance of recurrent rather than non-recurrent cost improvement programmes and the need for the committee to consider the detailed financial plan for 25-26. Can we note that? We also are noting the escalations for information from the 13th of March 2025 in respect of the committee's concerns around the underlying financial position and how that might affect the system's exit from NOF4 moving into 25-26. To note also the underlying run rate and whole-time equivalents were still risks in the finances, that there was still a risk around urgent and emergency care, the workforce controls and the drift on whole-time equivalents, and finally the discussions had started in respect of the assurance that the committee and NHS Devon board would need in respect of the 25-26 financial plan. We're also asked to agree the recommendation to approve the implementation of a single financial and procurement system through a digital partnership with NHS Shared Business Services. Are we happy to agree that recommendation? Thank you very much, and thank you, Kirsty and team, for all the work that has been happening in terms of the year end and also in terms of the 25-26 plan. Thank you for that. We now move to the Board Assurance Framework, and I'll ask Philippa to introduce this item. Thanks, Philippa.
Thank you. This is the last time that the board will see the Board Assurance Framework in this current form. I think I won't go into a huge amount of detail as ever. I think the paper is fairly self-explanatory. I do think it's worth flagging as ever the fact that the BAF has been pretty static throughout this year. I feel that this is a function of the the fact that we took the NHS oversight framework themes as our risks, which were very broad. And I think that the approach that the board has approved this meeting to move towards risk, to thinking about the strategic objectives as set out in the 25-26 annual plan, will give us a greater level of granularity and will enable us to have a lot more grip in terms of the board assurance framework and the ability for the board to be assured about the delivery of those strategic objectives. So I think that's probably the key issues that I think is worth raising in relation to this report at this time.
Thank you, Philippa. Any questions for Philippa on the board assurance framework? Okay, if not, then we're asked to approve the content of the latest iteration of the 24-25 BAF risks to achieving the strategic objectives of NHS Devon. Are we happy to approve that recommendation? Thank you very much. We move on to the partnership working section of the agenda. 6.1 is the One Devon Integrated Care Partnership update. Mary, is there anything that you would like to highlight from your report or add to the report? Mary, could you put the microphone on, please? Thank you.
It was good to have the first meeting and to get that sorted. And I think what I'm looking forward to, we're going to have a development session that's going to be arranged. And I think we need to look at the membership to see that we've got the right people around the table. Yeah, I'm positive. And unfortunately, as I say, there's elections coming up, so we're time constrained with Devon, and so that we have to sort of make sure that that's in that tolerance level. So, yeah, hopefully by the time we come round, because they're now going to be quarterly rather than 8 times a year, so we should have some progress to be able to report.
Thanks, Mary, and thanks for all the work that you're putting into the establishment of this committee. Any questions for Mary? If not, then we move on to item 6.2, which is the report from the Cornwall and Isles of Scilly ICB. I think that Kate has left the meeting, actually, so, but is there anything anyone wants to flag up from this report? If not, then we will note the report from the Cornwall and Isles of Scilly ICB. We move on to item 7 now, which is the remaining committee chair reports, and we go first to the Audit and Risk Committee, and over to you, Graham.
Thank you. So we met on the 12th of March. The chair's report did get amended, but somehow not the version that's in the pack. So I'll point out two things as I go through that. So where we are, I guess we have some standing agenda items, but we also have the financial cycle of activities. So we're clearly not quite, but nearly at financial year end. So our focus has been around looking at forward plans, be it internal, external, audit and forward, and prepping for year end. So in that sense, there's not too much to report at this point. That said, in the standing parts of it, we looked at the internal audit programme. There are 6 pieces of work that have been completed since we last met. There are 7 that are to be completed, but are in the works. I think we're in a reasonably good position this year. There's been a bit of a history of them being rather backloaded through the year, and there's a bit of a rush to them, and obviously that is a problem in terms of then forming an opinion. But given the state that we are, we did get tabled a draft view of that, and that's one of the amendments. Is I think the wording is perhaps a bit not caveated sufficiently, that this is a draft, an emergent view on that opinion. So I want to be cautious myself in it, but thus far it certainly is looking as though we are in a much better position this time than we were this time last year. So I think much credit should be given to all sorts of people in all sorts of places that our audit colleagues are seeing us as having improved as an organisation in many of those domains that they've explored. But it is draft, which is why I wanted to amend the wording a little bit around that. There are two reports there that will also go to the Audit Chairs Committee that is coming up quite soon. One which was commissioned by that group, which was around maternity services. This is a piece of work that has potentially both a patient and a financial implication, in that it can potentially reduce our expenditure to NHS resolution for negligence. That came out with some good recommendations, but nothing, I think, of note for the board. But we will look at that audit chairs group. The other one, which we will also take to that group and other places, is there was some work done by RSP individual around the workforce controls, the adequacies of that. Again, nothing dramatic to report from that. There were some good solid recommendations, except I think Piers and you and I have already discussed about those. The gist of them tends to be around consistency. But I think we're all aware that as we move forward, that will continue to be an important vehicle to enable us to deliver our plans. So I think we're quite keen that that report has landed correctly in the right places across the system, not just at an audit and risk committee. Two or three things to just note to the board, but they don't require action. There was some discussion around terms of reference and whether we would or would not like to keep an option of a co-opted independent member. I think there was a little bit of concern about some of the wording about a sort of system-wide role in coordination and the like, which we felt was something to be done, but possibly not in the terms of reference with the committee. I've already talked about the workforce controls report, which we wanted to make sure is landing in the right place. And the last one is that, which is also an error in the report, it references KPMG in their work for the mental health investment standard and references the last year rather than the current year. But in their work planning, we noted that they had completed the work for the previous year, and actually it hadn't really got the visibility it deserves, and therefore we wanted to highlight to the board that in this next cycle we would appreciate some board time to be able to report on that standard. The last year there was some confusion about whether dementia should or should not be included in that standard, but the bottom line was that when we excluded that, we actually did not achieve the standard. So that's a little bit of history, but we just wanted to make sure it has visibility when we see the new assessment of our compliance or not. So at that point, I think I will stop and take any questions.
Thank you, Graham. Any questions for Graham on his report from the Audit and Risk Committee? Lopa.
Just clarification on the independent co-opted member. Just what was the conclusion? I missed that. Apologies.
There is an inconsistency between the constitution that doesn't have it being struck out, but the terms of reference to the committee still includes it. We did have an independent member, actually was a former member of this board on that committee, and their time expired in Christmas. So I think we felt the view that we would rather have it in there as an opportunity. Whether we wish to exercise it or not would be a different question. This was bringing somebody in from outside of the board to potentially provide a fresh pair of eyes, which I guess, Martin, to some extent you've been able to do as well, bringing expertise into it, but without perhaps the closer position of being on the board.
Can I ask Philip to comment on that as well, please?
Thank you. So each of the board assurance committees received a report on its effectiveness, and one of the which was developed through conversations with the chairs and senior responsible officers of each of the board assurance committees as well. And a cross-cutting theme across all the committees was whether or not they would benefit from a co-opted member. So we had planned at the board development session in April to have a board discussion about a consistent approach to co-opted members across all our board assurance committees. We do have a co-opted member policy. However, I think we just need to have a look at the timing of that discussion in a little bit more detail.
Thanks, Lopa. Thanks, Graham. Thanks, Philippa. So if there are no further questions, we're asked to take assurance from the report of the Chair of the Audit and Risk Committee. Do we take assurance? Thank you. We're asked to note the escalations to the Board for information in respect of amending the corporate governance framework if NHS Devon accepts the proposal to take on delegated responsibility for specialised commissioning from NHSC. And secondly, ensuring more visibility as to how NHS Devon was performing against the mental health investment standard. And I think there was a request there for us to set aside some board time to understand that, which we'll leave with Philippa. And then also the proposed approach for linking across the system, Audit Assurance and Risk Chairs Forum, the Finance and Performance Committee and the People and Organisational Design Committee regarding progress on implementation of recommendations from the RSP System-Wide Workforce Controls Audit Review, and in addition on future work being undertaken on workforce controls. Thank you. And the other note, recommendations to the board has been covered earlier in the corporate governance section at 4.2 on the agenda. So we note that. Thanks very much. We now move to 7.2. Tandy, who is chair of the Population Health Improvement Committee for the 12th of March. Is there anything you want to add to your report, Tandy?
Oh, sorry. No, not really. I don't have very much to add to it. It's a very short report, and as you will notice, this was only the second time that this committee is meeting. So it's sort of still at that stage where it's regrouping and trying to see how it can improve this agenda. Obviously, there's a couple of things that we did look at, which included the BAF risk and checking whether we actually want that to be revised, given how far or how not far we are in terms of achieving that objective. We then also did look at committee effectiveness, but again, being the second committee, I think it was more about reflecting on what the committee could become and how we can feed into all the agendas, as well as looking at areas that actually might cross over between this committee in particular and the Quality and Patient Experience Committee, and whether there's need to have some joint meetings on particular agendas. But this is a growing debate in that particular committee, and this will be the last time I actually report to you as chair on that committee, because Lopa will be taking on the next one. But I'm very pleased that this committee is actually starting to sort of get a grip with these issues, and hopefully in 12 months' time we'll be in a much different place than we are now. Thank you.
Thanks, Tandy, and thanks for holding the reins on this committee while we were recruiting to our NM post. Really appreciate you doing that. Are there any questions for Tandy? If not, we take assurance from the report of the Chair of the Population Health Improvement Committee, and we note the recommendation that the Board approves the People and Communities Framework, which was done earlier in the meeting today. Thank you, Tandy. Let's move to 7.3 and the report from the Chair of the People and Organisational Development Committee. Over to Judy for 2 reports. Thank you.
Thank you very much. There are 2 reports here. The second one on the 19th of March was the one where we discussed the staff survey, and I've already picked that up earlier on today. The one on the 12th of February was again our second or third meeting, so we're still at a point of making sure that everybody understood the way in which the People and OD focus across the system is going to work constructively through this committee. We did discuss the workforce dashboard, and in line with what you've said about the audit committee looking at developments in that, we're very clear that, I mean, massive progress has been made from having very little information on workforce coming to the ICB a year or so ago. We're getting much better information, which means that tracking is possible, but there's still a lot of additional information, for example, the whole area of overtime and how that links to establishment and how it links to use of agency staff or not using agency staff. And so that's still an area in development. I say that because it came up just now. It wasn't an area we highlighted to raise to the board. There are two things to raise to the board. One is that we have been relying on external funding to help the system develop new roles. This is the Level 7 apprenticeship funding, and there's a review of this nationally. We don't know until next week, I think, April, there's a report due. But there's some really super work going on. I'm sure Piers' staff will share it in terms of developing people to advanced practitioner roles for this new ways of working. But the funding for that might be at risk. So keep an eye on that one. And the second one is that, and it's in a separate paper, we have to recommend your approval of the gender pay gap report. Approval feels really hard because our gender pay gap is bad. It's not brilliant. I urge you to approve the report because it has good information in it that the staff have, through 2 or 3 meetings and discussions, really worked on to understand how our gender pay gap works at different levels in the organisation, and they have a very good action plan. So I would, as chair of the committee, urge your adoption of it, but we are not in a good position on this issue, not through any ill intent or ill will, and indeed quite a lot of things have happened over the last year to make sure that interviews are better done so that there is a real understanding of potential bias, but it's an area the board will want to ask the people team and everybody else to do more on over the coming year. And that's it, Chair.
Thank you, Judy. Any questions for Judy from the People and Organisational Development Committee reports? Okay, in that case, we take assurance from the reports of the Chair of the People and Organisational Development Committee. We note the escalation to the Board for information of the Committee's views of the 2024 staff survey results, which was covered earlier in the meeting, and also the potential impact of funding risk relating to the government decision to defund Level 7 apprenticeships, which we will have, we think, further information next week. And are we happy to agree the committee's recommendation to approve the gender pay gap report? Thank you for that. Thank you, Judy. We're into the closing items now. We have one question from a member of the public. This is from Florence Bate, who has asked, please can you share your vision for the future of dementia care and the impact of an ageing population on healthcare provision in Devon? And I'm going to ask our Chief Medical Officer, Peter Collins, to respond to that. Peter.
Thank you for the question. So I'm really grateful for our mental health, learning disability and neurodiversity collaborative, who have been taking the lead on a multi-stakeholder engaged dementia strategy, which is approaching completion. And as a board, we'll consider what the next steps are in terms of making sure that we follow national best practice clinical effectiveness advice on how to deliver dementia services for our population. Clearly, the focus will be on early detection, allowing those who suffer with dementia and their families and carers to live as long as possible at home and in their communities, supported by all of the agencies, voluntary sector organisations who can help deliver a comprehensive service, and also making sure that we have services that are appropriate for those who have advanced and complex dementia.
Thanks, Peter. Do we have timescales on when the board will become more involved in that?
Certainly, we would expect over the next, as part of our development of our strategy, clearly our population demographics, we would all recognise that the population of Devon, as they get older, we will expect to see, as there is nationally, an increase in the diagnosis of dementia, and so it will form part of the strategic work that we're doing over the next 2 quarters.
Thank you, Peter. Any questions for Peter on that? And thank you to Florence Bate who submitted that question. Thanks, Peter, for your response to it. Is there any other business for the board meeting today? If not, then we can close the meeting, noting that the date of the next board meeting in public will be the 29th of May 2025. Thank you very much, everyone.